Okay, after a long struggle with small things, I think we are live again. क्या आप लोग सब हो? डॉक्टर नाइस, कैन यू सी मी? मतलब ये पहले वाला मैसेज है कि पुराना है कि पहले वाला अभी का है? डॉक्टर नाइस, आर यू देयर? हाय सर, हाँ गुड. डॉक्टर नाइस, क्या कैन वी कंटिन्यू नाउ? सब ठीक है? आवाज़ वगैरह वगैरह सब, लाइट वगैरह जो भी है. ओके चलो, तो अभी कंटिन्यू करते हैं विदाउट वेस्टिंग एनी फर्दर टाइम. मैं आपको पढ़ के बताऊंगा और वो आपको मतलब आप देख लो, मेरे साथ साथ आप भी आंसर कर लो. ओके हाँ, हाय. ओके, ऑल क्लियर, ठीक है. आई कैन स्टार्ट, लेकिन कैन यू नाउ रीड व्हाट इज रिटन ऑन द बोर्ड? एटलीस्ट लिटिल बिट. मैं भी पढ़ता हूं साथ में. ओके अगर थोड़ा कम दिखाई दे रहा है तो मैं साथ में पढ़ूंगा. आई होप यू कैन सी नाउ. कैन यू सी दिस ऑन द बोर्ड? तो अगर येस तो एक थम्स अप दिखा दो. अभी टाइम वेस्ट नहीं करते, स्टार्ट कर देते हैं. येस चलो, थैंक यू डॉक्टर नाइस, थैंक यू, सो नाइस ऑफ यू टू हैव द पेशेंस. आप लोगों ने पेशेंस दिखाया, उसके लिए बहुत बहुत धन्यवाद. और अभी हम स्टार्ट करेंगे. मैंने आपको पहले ही बताया है, इस वीडियो के एंड में मैं आपको फिजियोलॉजी के जो सिस्टम्स है और उसके जो टॉपिक्स है, 50 टॉपिक्स टू बी रेड फ्रॉम फिजियोलॉजी, उसकी पीडीएफ इस वीडियो के एंड में लिंक में कमेंट सेक्शन में लिंक पोस्ट कर दूंगा. वो 50 टॉपिक्स ही करना है आपको, उससे बाहर कुछ देखो ही मत. उतने 50 टॉपिक्स रैपिड रिवीजन में से खत्म करो, बात खत्म. आपको फिजियो में से जितने भी मतलब 15 एमसीक्यूज आएंगे या जितने भी आते हैं कम ज़्यादा, उसमें से 90% एमसीक्यूज आपके सॉल्व हो जाएंगे अगर आप ये 50 टॉपिक्स ठीक से करते हो. तो छोटे छोटे टॉपिक्स है, लाइक एक्टिव ट्रांसपोर्ट वगैरह वगैरह, इस टाइप के है. ओके तो मैं वो लगा दूंगा. हाँ डॉक्टर नाइस, थैंक यू. ऐसा कोई चाहिए होता है, आई डोंट नो. डॉक्टर नाइस ये आपका नाम नहीं है, आपका नाम कुछ और है, लेकिन ऐसा कोई चाहिए होता है बताने वाला कि इट्स डोंट वरी सर, अभी ठीक है वगैरह. क्योंकि सर तो पैनिक होंगे ही ना, लाइव सेशन है, बच्चे रुके हुए हैं और टाइम वेस्ट हो रहा है, तो ये पैनिक वाली सिचुएशन होती है. खैर चलो, तो वो टॉपिक्स आप लेक्चर के एंड में वो ज़रूर उठा लेना पीडीएफ. ओके जिसमें वो 50 टॉपिक्स होंगे जो एफएमजी के लिए इस साल के लिए मैंने निकाले हुए माय टॉप 50 बस. और छोटे छोटे टॉप 50 मतलब आप बोलो 50, ऐसा 50 ही नहीं है. एक्टिव ट्रांसपोर्ट या हार्ट रेट या ग्लूकोज ट्रांसपोर्ट या ऐसे टॉपिक्स है, तो हो जाएंगे आपके. मैं 50 टॉपिक्स आज कवर कराने की कोशिश करूंगा, लेकिन वो आप देख लेना एक बार पीडीएफ. ओके चलो, तो लेट्स स्टार्ट. मैच द फॉलोइंग है. सो मैच द फॉलोइंग. देखो, अगर एमसीक्यू, मैंने एमसीक्यूज क्यों नहीं लिए, डेलिबरेटली नहीं लिए, उसकी कारण है. एग्जाम नज़दीक है, एमसीक्यूज में रॉन्ग ऑप्शंस होते हैं और रॉन्ग ऑप्शंस दिमाग में बैठ जाते हैं. ये मेरा एक्सपीरियंस रहा है बच्चों के साथ, और इसलिए मैंने एमसीक्यूज थोड़े से ही लाए हैं और बाकी ऐसे लिए हैं कि रॉन्ग ऑप्शंस दिमाग में ना बैठे. चलो तो लेट्स स्टार्ट. आंसर की को मैं कवर कर रहा हूं, आप बताओ. टाइडल वॉल्यूम, टाइडल वॉल्यूम 500 ml, तो 1 का बी हो गया. इंस्पिरेटरी रिजर्व वॉल्यूम, अच्छा जॉय जी आ गए, वेरी गुड, वेलकम. इंस्पिरेटरी रिजर्व वॉल्यूम 3000 ml. एक्सपिरेटरी रिजर्व वॉल्यूम 1100 ml. आई होप कि यू आर टाइपिंग द आंसर्स. चलो ठीक है. एक्सपिरेटरी रिजर्व वॉल्यूम 1100 ml. रेसिडुअल वॉल्यूम 1200 ml. ये बाय हार्टेड रहा होगा आपको, तो इसमें कुछ बताने की जरूरत नहीं है. एंड डेड स्पेस वॉल्यूम 150 ml. अच्छा तो सुनो, डेड स्पेस का वॉल्यूम जो है आपने लिखा है बराबर, द बैटिस्टा। ठीक है ठीक है, आप सब लोग लिख रहे हो, थोड़े से लैग की वजह से आपके आंसर्स मुझे बाद में मिल रहे हैं, लेकिन आपको थोड़ी एडिशनल इंफॉर्मेशन बताता जाऊंगा, वो भी सुनो। डेड स्पेस वॉल्यूम इज 1 ml पर पाउंड ऑफ द बॉडी वेट। आप 150 ml याद रखा है, अच्छी बात है, लेकिन एक्चुअली में आप सोचो, इमेजिन करो एक छोटा बच्चा, अभी न्यूबॉर्न बेबी, उसका डेड स्पेस का वॉल्यूम, और एक ओबेज एडल्ट, उसका इतना बड़ा बॉडी का वॉल्यूम, तो क्या दोनों का डेड स्पेस वॉल्यूम सेम रहेगा? नहीं रहेगा। एंड देयरफॉर डेड स्पेस वॉल्यूम इज 1 ml पर पाउंड ऑफ द बॉडी वेट। याद रख सकोगे? तो 70 kg हेल्दी एडल्ट जो होता है, 70 kgs मतलब कि 150 पाउंड्स रफली अप्रोक्सीमेटली, तो 150 पाउंड्स 150 ml, इस तरीके से वो 150 है। ठीक है, करेक्ट। और रेसिडुअल वॉल्यूम जो है वो 1200, करेक्ट। लंग वॉल्यूम्स एंड कैपेसिटीज के ऊपर एफएमजीई में एक ना एक क्वेश्चन आता ही है, इसलिए मैंने पहली स्लाइड ये ली थी। चलो आगे बढ़ते हैं। कार्डियोवास्कुलर सिस्टम, ये आपको फॉर्मूले बताने हैं, तो बताओ। सिस्टोलिक बीपी, डायस्टोलिक बीपी, पल्स प्रेशर, मीन आर्टीरियल प्रेशर एंड मीन सिस्टमिक फिलिंग प्रेशर। सिस्टोलिक बीपी 120, डायस्टोलिक बीपी 80। अब इसके बाद के सारे प्रेशर आप कैलकुलेट करके मुझे बताओ, क्योंकि मीन आर्टीरियल प्रेशर या ब्लड प्रेशर के ऊपर एक ना एक क्वेश्चन इस बार आने का चांस है, मुझे लग रहा है ऐसा। हाँ, डेड स्पेस इज मोर इन एडल्ट्स, बराबर है आपने कहा। पठान जी, पठान अब्दुल खान जी, करेक्ट, आप राइट है। सिस्टोलिक बीपी 120, डायस्टोलिक बीपी 80, ये दो तो हो गए, अभी आप देख पा रहे हो बाकी के। व्हाट विल बी द पल्स प्रेशर? पल्स प्रेशर क्या होगा? ओके, तो सुनो, पल्स प्रेशर इज द डिफरेंस बिटवीन सिस्टोलिक एंड डायस्टोलिक ब्लड प्रेशर्स। एक काम करते हैं, मैं ब्लैक वाला भी ओपन करके रखता हूं, दैट विल बी बेटर। हाँ, पल्स प्रेशर कितना होता है? सिस्टोलिक माइनस डायस्टोलिक ब्लड प्रेशर, ये हो गया पल्स प्रेशर। अभी आते हैं मीन आर्टीरियल प्रेशर। मीन आर्टीरियल प्रेशर इज द एवरेज प्रेशर इन द वेसल्स ड्यूरिंग कार्डियक साइकिल। तो मीन आर्टीरियल प्रेशर इज, एनीबडी? हाँ, मैं फॉर्मूला वही आपसे पूछ रहा था पठान जी, पठान अब्दुल खान जी। मीन आर्टीरियल प्रेशर का फॉर्मूला है डायस्टोलिक ब्लड प्रेशर प्लस 1/3 ऑफ पल्स प्रेशर। तो ऐसा एमसीक्यू आ सकता है आपको, सिस्टोलिक डायस्टोलिक दिया है और मीन आर्टीरियल प्रेशर कैलकुलेट करने को बताया है, तो इट विल बी डायस्टोलिक बीपी प्लस 1/3 ऑफ पल्स प्रेशर। ओके, कैन यू बाय हार्ट इट नाउ? डायस्टोलिक बीपी प्लस 1/3 ऑफ पल्स प्रेशर। और सिस्टोलिक और डायस्टोलिक अगर 120 और 80 है तो अब कैलकुलेट करके मुझे बताओ। अच्छा, लास्ट ऑप्शन वॉज मीन सिस्टेमिक फिलिंग प्रेशर, मीन सिस्टेमिक फिलिंग प्रेशर या मीन सर्कुलेटरी फिलिंग प्रेशर, मीन सर्कुलेटरी फिलिंग प्रेशर। इससे मिलता जुलता एक एमसीक्यू कुछ साल पहले आया था, एक्चुअली नीट पीजी में आया था। व्हाट विल बी द प्रेशर इन द डेड, ऐसा एमसीक्यू आया था। हे, 129 कैसे आया मीन आर्टीरियल प्रेशर? कुछ तो गड़बड़ है जॉय, कुछ तो गड़बड़ है आपके कैलकुलेशन में। फिर से एक बार कैलकुलेट करना जॉय, 120 कहां से लाए आप? अरे डायस्टोलिक बीपी वाज 80 और पल्स प्रेशर वाज 40, पल्स प्रेशर 40 था, तो 40 का 1/3 कितना आया? 13। तो 80 प्लस 13 करना था आपको। मीन आर्टीरियल प्रेशर वाज 93 mm ऑफ Hg। हाँ नहीं टाइपिंग एरर, लेकिन फिर भी 129, 120 तो सिस्टोलिक बीपी दिया था ना। ले मैं चेक करता हूं एक बार। हाँ ये था, ओके 120 और 80 था सिस्टोलिक और डायस्टोलिक ब्लड प्रेशर्स। हाँ 93 करेक्ट। नयन पी 93, पठान जी 93, सबने 93 लिखा है, बराबर है, करेक्ट है, तो अब सही है। अच्छा हाँ मैं आपको बता रहा था कि अपना क्या बता रहा था यार, ये टेक्निकल ग्लिच ने मेरा कभी भुला दिया सब कुछ। हाँ सॉरी, मीन सिस्टेमिक फिलिंग प्रेशर या मीन सर्कुलेटरी फिलिंग प्रेशर। अभी बचा हुआ एक ही ऑप्शन है 6 mm ऑफ Hg, तो इसका आंसर 6 है। लेकिन मेरी बात समझो, क्या है ये प्रेशर, इसके ऊपर ओके 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 समझ गया जो है, ओके पढ़ लिया मैंने मैसेज। अच्छा तो सुनो, इसके ऊपर एक एमसीक्यू, पुराना एमसीक्यू आ चुका है नीट पीजी में, वो ये था व्हाट विल बी द प्रेशर इन द डेड। ओके अब मैं पूछता हूं, आप सोच के जवाब देना। 0 mm ऑफ Hg, 6 to 7 mm ऑफ Hg, 20 mm ऑफ Hg या 36 mm ऑफ Hg, बताओ व्हाट विल बी द प्रेशर इन द डेड। यानी अभी अभी उसका हार्ट रुका हुआ है और आप प्रेशर मेजरमेंट करने की कोशिश कर रहे हो, तो उसमें प्रेशर कितना होगा? 0 होगा, 6 होगा, 20 होगा या 30 क्या बोला मैंने, 36 होगा। हाँ डॉक्टर नाइस इज रियली नाइसली गिविंग मी मॉरल सपोर्ट। अरे टेंशन नहीं लो आप कह रहे हो, लेकिन टेंशन तो आती है ना, और टेंशन इसलिए आती है कि एग्जाम आपको देनी है, और अगर आपका टाइम वेस्ट हो और उसके लिए पार्टली अगर मतलब ये लेक्चर चालू नहीं हुआ ऐसा वगैरह, तो ज़रा ऐसा स्ट्रेस आ जाता है, बस बाकी कुछ नहीं। ओके ओके तो काफ़ी लोगों ने 6 लिखा है। हाँ नयन जी भी कह रहे हैं कि यस सर डोंट टेक टेंशन। वी आर विथ यू सर, सब पास होंगे। हाँ ये चाहिए भाई। अल्टीमेट विजन क्या है, अल्टीमेट गोल क्या है कि अपने सारे सेशंस जो है वो एकदम प्रोडक्टिव हो, फ्रूटफुल हो और आप सब निकल जाए, आपकी एग्जाम निकल जाए, आपको मतलब मिल जाए डिग्री। ये अल्टीमेट एम है, इसलिए तो थोड़ा स्ट्रेस आता है यार, पैनिक होने का वो होता है। खैर कोई बात नहीं, अच्छी बात है, और आप लोग बहुत मतलब सपोर्ट कर रहे हो, मॉरल सपोर्ट बहुत अच्छा लग रहा है मुझे। अभी अच्छा होएगा, नाउ आई विल रिलैक्स लिटिल बिट। ओके चलो, मीन सिस्टेमिक फिलिंग प्रेशर। तो क्या होता है ये प्रेशर, सुन लो। देखो हार्ट जब काम कर रहा है तब लेफ्ट वेंट्रिकल का पीक प्रेशर 120 mm ऑफ Hg, वो ब्लड को सर्कुलेट करवाता है थ्रू आउट द बॉडी। हाँ दैट इज क्रिएटिंग दैट फोर्स एंड द ब्लड इज फ्लोइंग। लेकिन जब हार्ट बंद पड़ जाता है तो अब ब्लड का क्या होगा, क्या वो सर्कुलेट होगा, क्या उस सर्कुलेटरी ट्री में ब्लड वेसल्स में कोई प्रेशर रहेगा? तो होता ये है कि ब्लड वेसल्स जो टिश्यू में है ना, टिश्यू का प्रेशर ब्लड वेसल्स पे पड़ता है आफ्टर हार्ट स्टॉप्स बीटिंग, और उसकी वजह से ना ब्लड जो है पूरी सर्कुलेटरी ट्री में, पूरी वैस्कुलर सिस्टम में एक बार फिर से रीडिस्ट्रीब्यूट होके फिल होता है, और उसको कहते हैं मीन सिस्टेमिक फिलिंग प्रेशर या मीन सर्कुलेटरी फिलिंग प्रेशर। हार्ट बंद पड़ने के बाद जो ब्लड फिर से दोबारा से पूरी सिस्टम में फिल होता है और फिर उसका एक प्रेशर रहता है, उसको कहते हैं मीन सिस्टमिक फिलिंग प्रेशर, और वो 6 mm ऑफ Hg होता है, क्योंकि टिश्यू का प्रेशर 6 mm ऑफ Hg है एंड टिश्यू इज प्रेशरिंग द वेसल्स, तो इसलिए उसके साथ वो इक्विलिब्रेट होता है पूरे ब्लड का प्रेशर एंड इट बिकम 6 mm ऑफ Hg। हाँ, करेक्ट, मीन सर्कुलेटरी, करेक्ट, डॉक्टर नाइस जी ने कहा है मीन सर्कुलेटरी फिलिंग प्रेशर इज 6 बट बीपी इज 0। यस, करेक्ट, ठीक है। तो मीन सर्कुलेटरी फिलिंग प्रेशर हो गया। आगे बढ़ते हैं, डाइजेस्टिव सिस्टम, आगे बढ़ते हैं। देखो और मुझे बताओ, पेप्सिन कौन से जूस में है? पेप्सिन, ट्रिप्सिन, अमाइनोपेप्टिडेज, टाइलिन एंड कोलिक एसिड, ये कौन कौन से जूसेस में है ये आपको बताना है। तो देखो और बताओ। आप 1 2 3 4 5 और उसके सामने ABCD लिख सकते हो। 1 पेप्सिन कहां पे है? गैस्ट्रिक जूस। ट्रिप्सिन कहां पे है? आपको दिखाई दे रहे हैं ना सारे ऑप्शंस? हाँ, गुड। अरे यार, आंसर की है यार, आंसर की मत देखो यार, सॉरी, ये आंसर की छुपी नहीं। करेक्ट, चलो तो फटाफट रिवाइज करते हैं। पेप्सिन गैस्ट्रिक जूस में है, ट्रिप्सिन जो है वो पैंक्रियाटिक जूस में है, अमाइनोपेप्टिडेज जो है, अमाइनोपेप्टिडेज इज एन एंजाइम इन द सक्कस एंटेरिकस। हमारी जो इंटेस्टिनल लाइनिंग है, स्मॉल इंटेस्टाइन की लाइनिंग, ब्रश बॉर्डर, उस ब्रश बॉर्डर में एंजाइम्स होते हैं। कौन से एंजाइम्स होते हैं? एक तो प्रोटीन के लिए ये है अमाइनोपेप्टिडेज, और उसमें होते हैं डाइसैकराइडेजेस, यानी सुक्रेज, माल्टेज, लैक्टेज, डाइसैकराइडेजेस, तो ये भी होते हैं उसमें। और टाइलिन, चलो ये बताओ, सूर्यांश जी ने लिख दिया है 1D बराबर है 2B बराबर है 3E बराबर है, उसके बाद टाइलिन सलाइवा बराबर। हेलो देवी कृष्णा जी, गुड आफ्टरनून देवी कृष्णा जी, वेलकम। तो आगे बढ़ते हैं। दिस मच ऑफ फिजियोलॉजी इज सफिशिएंट। 1 मिनट, हम सफिशिएंट ग्राउंड कवर करने की कोशिश कर रहे हैं, लेकिन सफिशिएंट का मतलब क्या? आपको इसके बाद ये टॉपिक्स पढ़ने एक बार रैपिड रिवीजन करना है, यानी ऐसा नहीं कि यही क्वेश्चंस ऐसे कैसे आएंगे। लेकिन जैसा मैंने कहा कि डाइसैकराइडेजेस आर प्रेजेंट इन द ब्रश बॉर्डर, तो ये एडिशनल इंफॉर्मेशन है, मैं भी बता रहा हूं, लेकिन थोड़ा आज के लेक्चर के बाद आप बुक में से भी देख लेना। ये जो मैंने क्वेश्चन सेट लाया है ना, इससे रिलेटेड सारी इंफॉर्मेशन आप देख लेना बस, ओके, दैट विल बी सफिशिएंट। और सफिशिएंट से मतलब क्या है हमारा ना, 15 MCQs आते हैं, तो क्या 15 के 15 आप सॉल्व करोगे उसको सफिशिएंट बोलोगे? 15 में से 10 सॉल्व किया उसको सफिशिएंट बोलोगे? तो सफिशिएंट ऐसा कुछ नहीं होता, मैक्सिमम आपने को आना चाहिए आंसर्स, ओके। और सोराब खान जी वेलकम। तो आप सब लोग आ जाओ, मैं सबको पर्सनली हाय हेलो कर रहा हूं, लेकिन आगे बढ़ते हैं। कोलिक एसिड गाइस, कोलिक एसिड बाइल में होता है। कोलिक एसिड इज प्रेजेंट इन द बाइल, कीनोडिऑक्सीकोलिक एसिड एंड यूरसियोडिऑक्सीकोलिक एसिड। चलो आगे बढ़ते हैं। जनरल फिजियोलॉजी है, अभी आंसर की मैं छुपा रहा हूं, तो आप पढ़ो और मुझे बताओ आगे का, ठीक है। ग्लूकोज एंट्री इनटू ऑल सेल्स, मतलब यहां पे मूवमेंट दिया हुआ है आयंस का या मोलेक्यूल्स का, और इस तरफ टाइप ऑफ ट्रांसपोर्ट दिया है। तो आपको जो जो आता है वो आप बताओ, मैं आपको टाइम दे रहा हूं, तब तक यहां पे पढ़ भी रहा हूं। ग्लूकोज एंट्री इनटू ऑल सेल्स ऑफ द बॉडी कैसे होता है बताओ? हाँ, थोड़ा फास्ट करता हूं, चलो। ग्लूकोज एंट्री, ग्लूकोज के ऊपर हमेशा क्वेश्चन आता है, तो मैं जस्ट बताना चाहूंगा, ये ग्लूकोज एंट्री into all cells is by facilitated diffusion. हाँ, using gluts, except GIT and kidney, GIT और किडनी में ग्लूकोज एंट्री ऑकर्स बाय SGLT. ये देखो, ये GIT है, यहां ल्यूमेन में ग्लूकोज है. अब ये एब्सॉर्प्शन होना है इनटू द ब्लड, तो ग्लूकोज विल एंटर द सेल बाय यूजिंग SGLT, और दूसरे साइड से निकल के ब्लड में चला जाएगा बाय यूजिंग GLUT2. तो आपको याद रखना है, ग्लूकोज लीव्स द सेल बाय यूजिंग GLUT2. कभी भी कहीं भी ग्लूकोज को अगर सेल के बाहर आना है तो इट ऑलवेज यूजेस GLUT2, जैसे कि यहां पर है. या फिर मसल में और लिवर में ग्लाइकोजिनोलाइसिस होता है, ग्लाइकोजन का ब्रेकडाउन होता है, ग्लूकोज बनता है और वो ब्लड में आके ब्लड का ग्लूकोज लेवल बढ़ाने वाला होता है. तो वो सेल के बाहर कैसे आता है? बाय यूजिंग GLUT2. ओके, तो ग्लूकोज के ऊपर एक क्वेश्चन कॉमनली आता ही आता है, SGLTs इन द GIT एंड किडनी. बिल्कुल सही बात है. आगे बढ़ते हैं. हाँ, सोडियम पोटेशियम पंप किस तरह का ट्रांसपोर्टर है? डी, प्राइमरी एक्टिव ट्रांसपोर्ट. सोडियम कैल्शियम एक्सचेंजर, सोडियम कैल्शियम एक्सचेंजर. चलो ये टाइप करो. ये किस टाइप का ट्रांसपोर्टर है? ये सेकेंडरी एक्टिव ट्रांसपोर्ट है. एंटीपोर्ट, सोडियम कैल्शियम एक्सचेंजर इज एन एंटीपोर्ट, सेकेंडरी एक्टिव ट्रांसपोर्ट. उसके बाद हाँ, चलो ये बताओ, ये सब लोग टाइप करो. चलो फटाफट. इंसुलिन सिक्रीशन बाय पैंक्रियाटिक बीटा सेल कैसे होता है? इंसुलिन जो पैंक्रियाटिक बीटा सेल में बनता है, वो बीटा सेल से बाहर कैसे आता है? बताओ, इसकी मूवमेंट क्या है? इंसुलिन सिक्रीशन बाय पैंक्रियाटिक बीटा सेल, इसमें से कोई चॉइस है? एनीथिंग? आप टाइप कर रहे हो और बीच में लैग है ना, इसके लिए. चलो मैं बता देता हूं. एक्सोसाइटोसिस, इंसुलिन सिक्रीशन ऑकर्स बाय एक्सोसाइटोसिस. एक काम करते हैं, पेन यूज करता हूं तो बेटर रहेगा. इंसुलिन सिक्रीशन, एक्सोसाइटोसिस. उसके बाद हाँ करेक्ट, सबने लिखा एक्सोसाइटोसिस और देवी कृष्णा जी ने सभी आंसर दिए हैं. ऑक्सीजन गोइंग फ्रॉम अल्वियोलस टू द ब्लड, सिंपल डिफ्यूजन. ऑक्सीजन फ्रॉम अल्वियोलस टू द ब्लड, सिंपल डिफ्यूजन. एंड वाटर मूवमेंट टू हाई कॉन्सेंट्रेशन, ऑस्मोसिस. चलो आगे बढ़ते हैं. ये क्या हो गया? नेक्स्ट, अब आएगा मजा गाइज, अब आएगा मजा. मैं क्वेश्चन पूछ रहा हूं, आपने अगर पहले ही ऑप्शन पे अगर आंसर कर दिया तो आपको मिलेंगे 30 मार्क्स, दूसरे पे क्या तो 20 मार्क, आखिरी पे क्या तो 10 मार्क्स. ऐसा वो एक क्लू बेस्ड क्विज है. ओके, तो बताओ, हु एम आई एम द लार्जेस्ट सेल इन द एक्स्ट्रा सेल्यूलर फ्लूइड. बताओ, आई एम द लार्जेस्ट सेल इन द एक्स्ट्रा सेल्यूलर फ्लूइड. एनी आइडिया? एनीबडी? अरे ऑलरेडी मोनोसाइट लिख दिया. सुभजीत शाह, वेलकम. मोनोसाइट, देवी कृष्णा जी ने भी लिखा है मोनोसाइट. यस दैट्स राइट. I have a horseshoe shaped nucleus. Monocyte has got horseshoe shaped nucleus and my count is just 2 to 8%. So answer is monocyte. Next, identify this process. Identify this process. Large molecules move into the cells by this process. Large molecules, foreign particles, bacteria, they enter the cells by this process. Identify the process. It involves crossing of the membrane but without going through the membrane. और तीसरा क्लू है LDLs, vitamins enter the cell by this process. Any idea? Okay, डॉक्टर नाइस जी ने ऑलरेडी आंसर दे दिया है इसका. करेक्ट, द आंसर इज एंडोसाइटोसिस. तो क्विकली बता दूं, एंडोसाइटोसिस मतलब लार्ज मोलिक्यूल्स एंटर द सेल बाय एंडोसाइटोसिस. और उसका एक एग्जांपल आपको याद रखना है क्योंकि ये एग्जांपल के ऊपर 2 बार एमसीक्यूज आ चुके हैं. वो एग्जांपल है एलडीएल्स, सर्कुलेटिंग एलडीएल्स, कोलेस्ट्रॉल एंटर्स द स्टीरॉयड सिंथेसाइजिंग सेल. हमारी जो स्टीरॉयड फॉर्मिंग सेल्स होती है ना, उनमें कोलेस्ट्रॉल कैसे एंटर करता है? बाय एंडोसाइटोसिस. याद रखना, एलडीएल एंट्री. नेक्स्ट, आइडेंटिफाई मी. आई मेकअप द थिन फिलामेंट इन द मसल्स. आइडेंटिफाई मी. आई मेकअप द हाँ, सबने एंडोसाइटोसिस लिख दिया है, करेक्ट आंसर है. आई मेकअप द थिन फिलामेंट इन द मसल्स. कौन हूं मैं? आई हैव एक्टिव साइट्स ओवर मी. तो थिन फिलामेंट पे एक्टिव साइट्स होते हैं, मायोसिन के हेड्स उसके साथ इंटरेक्ट करते हैं, लेकिन ये थिन फिलामेंट के किस मोलेक्यूल पे होते हैं बताओ? एंड आई इंटरैक्ट विथ मायोसिन. अब बताओ, अब तो आंसर आ जाएगा. सो कॉन्सेप्ट ये आपको पढ़ना है क्योंकि ईसी कपलिंग और सार्कोमेर, इसके ऊपर एक ना एक क्वेश्चन एफएमजी में आता ही आता है. सो प्लीज ये प्रॉपरली प्रिपेयर कर लेना. ओके, हम ये कर रहे हैं ना, इसके बाद मैं वो टॉपिक लिस्ट पुट अप कर दूंगा. अगले 2-3 दिन में, 2 दिन में या 3 दिन में वो टॉपिक लिस्ट खत्म कर लेना, उतना पढ़ लेना. ठीक है, चलो. इसका आंसर था एक्टिन. तो याद रखो, थिन फिलामेंट इज मेड अप ऑफ 3 मॉलिक्यूल्स: एक्टिन, ट्रोपोनिन, ट्रोपोमायोसिन. एक्टिन उसके ऊपर है एक्टिव साइट्स, ओके, विच आर केप्ट कवर्ड बाय ट्रोपोनिन ट्रोपोमायोसिन कॉम्प्लेक्स. आगे बढ़ो. हु इज दिस? ही इज अ केमिकल फ्रॉम द आइलेट्स. केमिकल फ्रॉम द आइलेट्स. हाँ, most other chemicals are anti him. Most of the other chemicals in the body are anti this molecule, yeah, this chemical. Banting and Best discovered him in 1921. क्या है इसका आंसर बताओ? तब तक मैं इसके एंटी जो है वो लिख देता हूं. आंसर था इंसुलिन. इट डिक्रीजेस द ब्लड ग्लूकोज. और एंटी इंसुलिन हार्मोन्स के नाम सुनो: ग्रोथ हार्मोन, ग्लूकागॉन, कैटेकोलामाइंस, सब एंटी इंसुलिन है. और कोई याद आ रहा है आपको? और कोई हार्मोन जो याद आ रहा हो? हाँ, इंसुलिन करेक्ट था. उसके बाद सोमैटोस्टैटिन, ये भी एंटी इंसुलिन है. इट इनहिबिट्स द इंसुलिन सिक्रीशन. करेक्ट. सो इन दैट सेंस, tug of war between insulin and other hyperglycemic agents. So these are hyperglycemic agents. Hyperglycemic agents, इनके नाम याद रखो. They all cause hyperglycemia. आगे बढ़ते हैं. हाँ, identify this protein. It transmits the tension from inside to outside. ये थोड़ा टफ है, दिमाग लगाओ. आइडेंटिफाई दिस प्रोटीन. इट ट्रांसमिट्स टेंशन फ्रॉम इनसाइड टू आउटसाइड. अब ये कौन सा टेंशन, किस बात का टेंशन? लार्जेस्ट ह्यूमन जीन एनकोड्स दिस प्रोटीन। लार्जेस्ट ह्यूमन जीन कौन सा है पता है आपको? सोचो। और तीसरा है इट्स डिफेक्ट रिजल्ट्स इन मस्कुलर डिस्ट्रॉफी। तो ये किसकी बात चल रही है बताओ? अरे हाँ, कोलाज जी ने लिखा कॉर्टिसोल, मैं रह गया वो। गाइज कॉर्टिसोल भी एंटी इंसुलिन हाइपरग्लाइसेमिक हार्मोन, वो लिखना रह गया। तो ग्रोथ हार्मोन, ग्लूकागॉन, कॉर्टिसोल, सोमैटोस्टैटिन, कैटेकोलामाइंस, ये सारे एंटी इंसुलिन है। चलो करेक्ट, इसका आंसर है डिस्ट्रोफिन एंड इट्स डिफेक्ट रिजल्ट्स इन डुशेनीज मस्कुलर डिस्ट्रॉफी। लार्जेस्ट जीन जो है वो डिस्ट्रोफिन जीन है और लार्जेस्ट प्रोटीन जो है वो टाइटिन है। आगे बढ़ो। व्हाट्स द गुड वर्ड? सब्सटेंसेस मूविंग अक्रॉस अ सेल। ये अरे यार इधर आंसर ऑलरेडी लिखे हुए हैं। ठीक है चलो ये पढ़ते जाओ फटाफट, मैं उसके रिलेटेड इंफॉर्मेशन आपको बताता जाता हूं, इसमें आंसर नहीं करना है। सब्सटेंसेस मूविंग अक्रॉस अ सेल मतलब यहां से अंदर गया और वहां से बाहर चला गया, इसको क्या कहते हैं? ट्रांससाइटोसिस। इफेक्ट ऑफ ऑक्सीजन ऑन कार्बन डाइऑक्साइड लिबरेशन इन द लंग्स। इफेक्ट ऑफ ऑक्सीजन ऑन CO2 लिबरेशन इन द लंग्स इज कॉल्ड एज Halden's effect. Halden's effect. Effect of CO2 on oxygen liberation by hemoglobin. That's called as Bohr's effect. तो Bohr effect, Halden effect, ये आपको आज के लेक्चर के बाद पढ़ना है। इसके ऊपर MCQs आते हैं, Bohr effect के ऊपर, 2-3 DPG के ऊपर। ओके नेक्स्ट, the neuron that continues to replicate throughout life, olfactory neuron. No new neurons are formed after birth except olfactory neuron. Okay, मैं ऐसे ही पूछ लेता हूं, आप आंसर लिख देना। देवी कृष्णा जी ने हैमबर्गर इफेक्ट लिखा है, हैमबर्गर इफेक्ट, ठीक है। मैं क्वेश्चन पूछ रहा हूं, विच ऑफ द फॉलोइंग इज कॉल्ड एज एट्रियल साउंड? एट्रियल साउंड S1, S2, S3, S4, 4 हार्ट साउंड्स होते हैं, उसमें से कौन सा जो है एट्रियल हार्ट साउंड कहा जाता है? बताओ। S1, S2, S3, S4। मेरी बैटरी ड्रॉप हो रही थोड़ी सी तो चार्जर लगा दिया। करेक्ट, S4 शुभम, S4। फोर्थ हार्ट साउंड इज कॉल्ड एज एट्रियल साउंड। और पता है क्यों? क्योंकि फोर्थ हार्ट साउंड इज कॉज्ड बाय टर्बुलेंस ऑफ ब्लड एंड दैट टर्बुलेंस ऑफ ब्लड लास्ट रैपिड फिलिंग इज कॉज्ड बाय व्हाट? इट इज कॉज्ड बाय एट्रियल सिस्टोल। तो आपको कार्डियक साइकिल पिट पैट करना पड़ेगा। कार्डियक साइकिल और JVP की इज द मस्ट डू टॉपिक। एक क्वेश्चन इस बार आपको सर्टनली कार्डियक साइकिल और JVP में से आएगा, 1 या 2 भी आ सकते हैं। S4, चलो बाकी सबने S4 लिख दिया है, करेक्ट है। एंड मैं पढ़ के बताता हूं। हाई फ्रीक्वेंसी स्टिमुलेशन ऑफ द मसल रिजल्ट्स इन, high frequency stimulation of the muscle results in what? बताओ, मैंने छुपा के रखा है आंसर, थोड़ा आपको सोचने के लिए। ओके, देवी कृष्णा जी कह रहे इट इज पैथोलॉजिकल ऑल्सो ना। देवी कृष्णा जी 4 हार्ट साउंड्स प्रोड्यूस होते हैं, ये तो पक्का है। 2 ही सुनाई देते हैं, S1 एंड S2, 2 ही सुनाई देते हैं। S3 एंड S4 नॉर्मली सुनाई नहीं देते, और अगर वो सुनाई दिए तो यस इट कैन बी पैथोलॉजिक। ओके, पर्टिकुलरली फोर्थ हार्ट साउंड इज हर्ड इन वेरियस कंडीशंस। मतलब CCF में भी फोर्थ हार्ट सुनाई देता है, फोर्थ हार्ट साउंड, या फिर माइट्रल स्टेनोसिस में कभी कभी फोर्थ हार्ट साउंड सुनाई देता है, तो वो है, ठीक है। चलो, high frequency stimulation of the skeletal muscle results in sustained state of contraction, failure to relax एंड इट इज कॉल्ड एज टिटेनस। तो क्या किसी ने लिखा है? टिटेनी नहीं, टिटेनस। हाँ, क्योंकि टिटेनी मैंने देखा ऑप्शंस में, फिर वो डिलीट किया है, लेकिन कोई बात नहीं। आई जस्ट टेल यू व्हाट इज टिटेनी एंड व्हाट इज टिटेनस। टिटेनी जो है उसमें डिक्रीज्ड ECF कैल्शियम, प्लाज्मा का कैल्शियम, ECF का कैल्शियम कम होने पर टिटेनी होती है। और वो कब होती है? हाइपोपैराथायरॉयडिज्म। हाइपोपैराथायरॉयडिज्म, तो पैराथायरॉयड हार्मोन के डिफेक्ट से, डेफिशिएंसी से होती है टिटेनी। चलो मैं आप सबको एक सवाल पूछता हूं। एक तो टिटेनी का रीजन बताया हमने, पैराथायरॉयड की डेफिशिएंसी एंड हाइपोकैल्सेमिया। दूसरा क्या रीजन है टिटेनी का? लिखो, देखता हूं किसका डिटेल में पढ़ा है फिजियोलॉजी का। हाँ, देवी कृष्णा जी कह रहे यू मिस्टूक इट फॉर टिटेनी। टिटेनी का एक कारण मैंने आपको बता दिया, हाइपोकैल्सेमिया। क्या दूसरा कारण आपको पता है? जो भी बता पाएगा उसको मेरी तरफ से एक, अब क्या दे सकता हूं, ओके, टेक अ बाव, ऐसा दे सकता हूं। तो बताओ, टिटेनी का एक कारण हाइपोकैल्सेमिया है, पैराथायरॉयड के डिफेक्ट की वजह से है। व्हाट इज द अदर रीजन? आई एम चेकिंग। हाइपोपैराथायरॉयडिज्म, पैराथायरॉयड का डिफेक्ट, उसके लिए प्लाज्मा कैल्शियम उसकी वजह से कम हो जाता है, और प्लाज्मा कैल्शियम कम होने की वजह से टिटेनी होती है। और टिटेनी के मैनिफेस्टेशन से ट्रोजूस साइन एंड श्वोस्टेक साइन, ट्रोजूस साइन एंड श्वोस्टेक साइन। हाइपरथर्मिया लिखा है, एक्चुअली टिटेनी का दूसरा रीजन है अल्कलोसिस। सो प्लीज नोट इट डाउन, अल्कलोसिस ऑल्सो रिजल्ट्स इन टिटेनी। ओके, रेस्पिरेटरी अल्कलोसिस रिजल्ट्स इन टिटेनी। और उसका कारण बताता हूं आपको। अल्कली जो होती है ना, अल्कली प्लाज्मा में, दे मॉप अप द सीरम कैल्शियम। सीरम में जो आयोनिक कैल्शियम है ना, तो अल्कलीज ना उसको निकाल लेती है, मॉप अप कर लेती है, और इसलिए अल्कलोसिस इज द अदर रीजन फॉर टिटेनी। एक कारण है हाइपोकैल्सेमिया, दूसरा कारण है अल्कलोसिस। एंड व्हाट इज टिटेनस? टिटेनस, sustained state of contraction and failure to relax which occurs from high frequency stimulation। और उसका कैल्शियम के साथ क्या कनेक्शन है? इंक्रीज्ड सार्कोप्लाज्मिक कैल्शियम। तो गाइज बाय हार्ट कर लो, ECF कैल्शियम, प्लाज्मा कैल्शियम कम हुआ, टिटेनी। सार्कोप्लाज्मिक कैल्शियम एक्सेस हो गया, टिटेनस। ओके, लिख के रखो। चलो नेक्स्ट, प्रेशर रिलेटेड इंजुरी टू द नर्व ट्रंक इज कॉल्ड न्यूरोप्रैक्सिया। तो फटाफट देखो, प्रेशर ऑन द नर्व ट्रंक सर्जरी में किया होगा आपने, न्यूरोप्रैक्सिया, सिर्फ प्रेशर हो गया तो। उसके बाद सिंगल एक्सॉन कट, तो उसको कहते हैं एक्सोनॉटमेसिस। एंड बंच ऑफ नर्व फाइबर्स आर कट, तो उसको कहते हैं न्यूरोटमेसिस। ओके, तो सिर्फ प्रेशर रिलेटेड इंजुरी ऑन द नर्व ट्रंक, न्यूरोप्रैक्सिया। फिर एक एक्सॉन अगर कट हो गया तो एक्सोनॉटमेसिस, और बंच ऑफ एक्सॉन्स मतलब बंच ऑफ नर्व फाइबर्स कट हो गए तो न्यूरोटमेसिस। सलाइवरी अमाइलेज इज कॉल्ड टाइलिन। सलाइवरी अमाइलेज इज कॉल्ड टाइलिन। सारे एंजाइम्स के नाम कर लो। सिंड्रोम ऑफ पोस्टपार्टम पिट्यूटरी नेक्रोसिस, बिना देखे आंसर बताओ। सिंड्रोम ऑफ पोस्टपार्टम पिट्यूटरी नेक्रोसिस इज कॉल्ड व्हाट? टाइप करो। पोस्टपार्टम पिट्यूटरी नेक्रोसिस इज कॉल्ड व्हाट? आई एम वेटिंग। मैंने आंसर छुपा के रखा है, आई एम वेटिंग, बताओ। एनीबडी राइटिंग? अरे वाह, डॉक्टर नाइस जी ने लिख दिया। मुझे ऐसा डाउट आ रहा है कि डॉक्टर नाइस ये जो आईडी है ये एक्चुअली मेरा ही कोई पुराना फेवरेट स्टूडेंट है, फर्स्ट ईयर से पढ़ता आया हुआ, जैसे सुभजीत जी है, बाकी सभी आप सब लोग मेरे फेवरेट स्टूडेंट्स हो। हाँ, मैं ये कह रहा हूँ कि डॉक्टर नाइस आईडी नहीं है ना, नाम नहीं है ना उसमें, इसलिए मैं ये कह रहा हूँ। बाकी आप सब लोग जॉय और सोहराब खान जी, देवी कृष्णा जी, आप सभी मेरे फेवरेट हो। और मैं एक बात बताऊँ आपको, आई एम द लकी चार्म। ऐसा बहुत सारे स्टूडेंट्स बोलते हैं सर आप, मैं अभी सिर्फ मतलब 1 मिनट के लिए बताता हूँ। बहुत सारे स्टूडेंट्स एग्ज़ाम के पहले मुझे मिलने के लिए आते हैं मेरे कॉलेज के, बोलते हैं सर आप लकी चार्म हो, आपको देख के अगर एग्ज़ाम को गए ना तो अच्छा रिजल्ट आता है, मतलब अच्छा पेपर भी अच्छा जाता है। तो आई एम टेलिंग यू, जितने भी लोग अभी मुझे सुन रहे हैं लाइव, लकी चार्म हूँ, आप सब लोग FMGE क्लियर करोगे इस बार, अच्छे मार्क्स आएंगे आपके। चलो तो शियान सिंड्रोम, ओ डॉक्टर नाइस जी कह रहे फर्स्ट टाइम स्टडीइंग फ्रॉम यू, ओके ओके, ठीक है ठीक है, एंड थैंक्स डॉक्टर नाइस जी। शुरू में मैं बहुत रैटल्ड था, वो टेक्निकल ग्लिच, स्टार्ट ही नहीं हो रहा है वो सेशन, तो आपने मुझे मॉरल सपोर्ट दिया, उसके लिए थैंक यू। चलो शियान सिंड्रोम, वेजोकॉन्स्ट्रिक्टर इन एरिया इन द मेडुला इज लोकेटेड वेयर? वेजोकॉन्स्ट्रिक्टर एरिया इन द मेडुला, तो सुनो, वेजोमोटर सेंटर होता है मेडुला में, उसके 3 मेन पार्ट्स होते हैं। एक न्यूक्लियस ऑफ ट्रैक्टस सॉलिटेरियस, NTS, दिस इज द सेंसरी न्यूक्लियस फॉर 9th and 10th नर्व। दूसरा RVLM, रोस्ट्रल वेंट्रोलैटरल मेडुला, यह है वेजोकॉन्स्ट्रिक्टर एरिया। और तीसरा कार्डियो इनहिबिटरी एरिया, जो BP को कम करता है, उसका नाम है डॉर्सल मोटर न्यूक्लियस ऑफ वेगस। ओके, अभी मैंने कवर करके रखा है, पढ़ के बताता हूं, आप आंसर बताओ। द न्यूरल सर्किट दैट डिस्क्राइब्स इमोशनल बेसिस ऑफ ह्यूमन बिहेवियर, द न्यूरल सर्किट दैट डिस्क्राइब्स इमोशनल बेसिस ऑफ ह्यूमन बिहेवियर, उसका नाम क्या है बताओ। ओके, देवी कृष्णा जी कह रहे हैं नोटेड, माय सीक्रेट विश। नहीं बट ये सच में है, मतलब बच्चे बोलते हैं ऐसा, सर आपको हेलो करके फिर मतलब आपको देख के जब जाते तो एग्ज़ाम अच्छा जाता है। कैजुअल छोड़ो, ये सब लाइटर वेन में मैंने कहा, सच बात है, लेकिन ऐसे ही बोस्ट नहीं कर रहा था, जैसे कह रहा था। बायोमैज कह रहे हैं पापुच सर्किट, स्पेलिंग करेक्ट करो, वो है पापेज सर्किट, PAPEZ, पापेज सर्किट। ओके, इमोशनल बेसिस ऑफ ह्यूमन बिहेवियर, पापेज सर्किट, PAPEZ। चलो एक एडिशनल पॉइंट पूछता हूं, देखता हूं कि किसको आता है। इमोशनल विंडो through which we see the external world, which part of the brain is called emotional window through which we see the external world? क्या नाम है उस part of the brain का? और that is a part of the limbic system, hint दे दिया। अब बताओ, हमारे ब्रेन का वो पार्ट जिसके थ्रू हम एक्सटर्नल वर्ल्ड देखते हैं, उसका नाम क्या है? Anybody? Anybody? CNS पढ़ा होगा आपने तो, इमोशनल विंडो थ्रू विच वी सी द एक्सटर्नल वर्ल्ड, विच पार्ट ऑफ द ब्रेन? एंड इट्स अ पार्ट ऑफ, अरे वाह डॉक्टर नाइस जी, आप सच में पहली बार मेरे से पढ़ रहे हैं, क्योंकि ये सारी चीज़ें जो मैं अपने लेक्चर्स में बताता हूँ ऑलवेज, आप फटक से आंसर दे रहे हो। फैंटास्टिक फैंटास्टिक, वेरी गुड। यस, द आंसर इज अमिगडाला। Amygdala is the emotional window through which we see the external world. बिल्कुल सही है. इमेज बेस्ड क्वेश्चंस, इमेज बेस्ड क्वेश्चन है. आ जाओ. अरे यार मैंने फिर से आंसर बता दिया, कोई बात नहीं. सिंगुलेट गायरस, पापेज सर्किट बताया, उसके स्ट्रक्चर्स बताए, क्योंकि ना अभी लास्ट 1-2 साल में पापेज सर्किट के ऊपर क्वेश्चन नहीं आया एफएमजी में, लेकिन उसके पहले ना एफएमजी में पापेज सर्किट बहुत बार पूछा गया, इसलिए मैंने लिया है, 2 बार लिया है. तो पापेज सर्किट क्या है ब्रेन में? सिंगुलेट गायरस कनेक्टेड विद दिस स्ट्रक्चर, जिसको ऐसे किया हुआ है. देन मैमिलरी बॉडी which is hypothalamus, then anterior thalamic nucleus and back to cingulate gyrus. That's the connection. तो ये स्ट्रक्चर कौन सी है? बोलो कौन सी स्ट्रक्चर है? Cingulate gyrus is connected with hippocampus. Hippocampus connected with mammillary body, hypothalamus की mammillary body, and that is connected with anterior thalamic nucleus and back to cingulate gyrus, completing the circuit. This is Papez circuit. Next, identify the secretion. Identify the secretion. बताओ ये कौन सा secretion है? आ जाओ. हाँ, पंकज पिक्सेल जी ने करेक्ट लिखा हिपोकैम्पस, और सोराब खान जी ने भी करेक्ट लिखा हिपोकैम्पस. आइडेंटिफाई दिस सिक्रीशन. आंसर पढ़ा नहीं ना? चलो पढ़ा होगा तो कोई बात नहीं, मैं बताता हूँ कैसे ढूंढना है आपको. ये एग्जाम में आ सकता था ऐसा क्वेश्चन. तो आपको क्या देखना है? प्राइमरी सलाइवरी सिक्रीशन कमिंग फ्रॉम द ब्लड. ये प्राइमरी सिक्रीशन है. इट इज कमिंग फ्रॉम द ब्लड. इट इज रिच इन सोडियम, क्लोराइड एंड वाटर. तो सलाइवा में प्राइमरी सलाइवरी सिक्रीशन है. इट इज रिच इन सोडियम, क्लोराइड एंड वाटर. लेकिन उसके बाद जब वो डक्ट में से फ्लो करता है तो देयर इज डक्टुलर मॉडिफिकेशन. ये डक्ट जो है उसको मॉडिफाई करती है. क्या मॉडिफाई करती है? तो सोडियम इज रीएब्सॉर्ब्ड, पोटेशियम इज सिक्रीटेड, क्लोराइड इज रीएब्सॉर्ब्ड, बाइकार्बोनेट इज सिक्रीटेड. तो डक्ट ने क्या ऐड किया? पोटेशियम और बाइकार्बोनेट. तो सलाइवा में मैक्सिमम कॉन्सेंट्रेशन किन 2 आयंस का है? पोटेशियम एंड बाइकार्बोनेट, जिनको डक्ट ने ऐड किया. और एक बात याद रखो, सोडियम निकाल लिया गया है लेकिन वाटर रह जाता है डक्ट में. सोडियम निकल गया सिक्रीशन से और वाटर रह गया, बिकॉज दिस सलाइवरी डक्ट इज इम्परमिएबल टू वाटर. इसलिए फाइनल सलाइवरी सिक्रीशन इज ऑलवेज हाइपोटोनिक. हाइपोटोनिक क्योंकि सोडियम कम है, निकल गया है, और वाटर है. आइडेंटिफाई द रिसेप्टर. कवर करके रखता हूं. आइडेंटिफाई द रिसेप्टर. ये एक लैमेलर ऑर्गेनाइजेशन वाला रिसेप्टर है. दिख नहीं रहा है ना? 1 मिनट. और उससे सेंसरी न्यूरॉन निकल रहा है. तो ये कौन सा रिसेप्टर है? सेंसरी रिसेप्टर विथ ऐसे ऑनियन लाइक लैमेले होते हैं. ये कौन सा रिसेप्टर है? क्या बता सकता है कोई? चलो मैं बताता हूं फटाफट. ये पैसिनियन कॉर्पस्कल है. पैसिनियन कॉर्पस्कल. और एक पॉइंट नोट करो क्योंकि इसके ऊपर 2-3 बार एफएमजी में क्वेश्चन आ चुका है. रैपिडली अडैप्टिंग वाइब्रेशन रिसेप्टर. रैपिडली अडैप्टिंग वाइब्रेशन रिसेप्टर इज पैसिनियन कॉर्पस्कल. वेरी रैपिडली अडैप्टिंग. तो वाइब्रेशन का रिसेप्टर कौन? पैसिनियन कॉर्पस्कल. आइडेंटिफाई द सेल. ये सेल देखो और बताओ कौन सी सेल है? बता सकते हो ये कौन सी सेल है? मैंने ये क्वेश्चन इसलिए लिया क्योंकि आजकल ना हिस्टोलॉजिकल या माइक्रोस्कोपिक अपीयरेंस वाले क्वेश्चंस आ रहे हैं बहुत सारे, इसलिए मैंने ये क्वेश्चन ले लिया। तो आइडेंटिफाई दिस सेल, कौन सी सेल है ये? हिंट देता हूं, लाल कलर के ग्रैन्यूल्स है और बाइलोब न्यूक्लियस है, बाइलोब न्यूक्लियस और लाल कलर के ग्रैन्यूल्स। तो कौन सी सेल है? करण कुमार जी, इओसिनोफिल है, क्योंकि लाल कलर के ग्रैन्यूल्स मतलब एसिडिक स्टेन को अट्रैक्ट करने वाले ग्रैन्यूल्स। ओके, ये 2 साल पहले एफएमजी के एग्जाम में कोई दूसरी सेल आई थी, मैंने ये अपने सेशन के लिए ले लिए ये सेल। तो ऐसे सेल दिखा के पूछते हैं कौन सी सेल है, आइडेंटिफाई करो। दिस इज इओसिनोफिल, बाइलोब न्यूक्लियस एंड रेड कलर ग्रैन्यूल्स। अभी आइडेंटिफाई द सेल इंडिकेटेड बाय द एरोज। ये सेल बताओ, एरोज ने दिखाई हुई सेल है। ग्लोमेरुलर कैपिलरी यहां पे है, कैपिलरी की एंडोथेलियल लाइनिंग, फिर बेसमेंट मेम्ब्रेन और यहां पे उसके बाहर ये सेल है। तो क्या आप बता सकते हो कौन सी सेल है ये? देखो, विच सेल इज दिस? जो एरो से पूछी गई सेल है, ग्लोमेरुलर कैपिलरी, फिर उसकी एंडोथेलियल लाइनिंग, एंडोथेलियम की बेसमेंट मेम्ब्रेन और फिर ये कौन सी सेल है? एनीबडी? अच्छा, मैं उसका हिंट दे देता हूं, इसकी फूड प्रोसेसेस होती है, फूड प्रोसेसेस। तो कौन सी सेल हो गई? हाँ, पंकज पिक्सेल जी ने करेक्ट आंसर दिया, पोडोसाइट। यस, इट्स अ पोडोसाइट। तो प्लीज याद रखो कि ग्लोमेरुलर कैपिलरी का जो हम बैरियर कहते हैं ना, फिल्ट्रेशन बैरियर, तो उस फिल्ट्रेशन बैरियर के 3 कंपोनेंट्स होते हैं कि किडनी में, ग्लोमेरुलाई में फिल्ट्रेशन बैरियर के 3 कंपोनेंट्स होते हैं। एक ग्लोमेरुलर कैपिलरी के एंडोथेलियल लाइनिंग, ये वाली, फिर बेसमेंट मेम्ब्रेन जिसके ऊपर वो एंडोथेलियल लाइनिंग होती है, और तीसरी है ये पोडोसाइट के फूड प्रोसेसेस। चलो करेक्ट, सो दिस इज पोडोसाइट। इस तरीके के क्वेश्चंस आते हैं। अब मैं फटाफट पढ़ते जाता हूं, आप सुनते जाओ। आइडेंटिफाई दिस केमिकल मोर कॉमनली फाउंड टू ओपन क्लोराइड चैनल्स इन द स्पाइनल कॉर्ड। कॉमनेस्ट इनहिबिटरी neurotransmitter in the spinal cord? Answer is glycine. Commonest inhibitory neurotransmitter in the brain? Answer is GABA. तो नोट डाउन करो अभी के अभी। Commonest excitatory transmitters in the brain are glutamate and aspartate. Excitatory transmitters, glutamate and aspartate. Inhibitory transmitters, GABA and glycine. GABA in the brain, glycine in the spinal cord. Next, अच्छा ये ऑलरेडी लिख दिया है। Identify this channel. It is a pentamer and the receptor associated with it is called as cis loop receptor, and the receptor channel complex is known as ionotropic receptor associated channel. Ligand gated ion channel इसका नाम था। खैर मैं बता देता हूं क्योंकि ऑलरेडी बहुत कुछ लिखा है इस स्लाइड में, पढ़ते पढ़ते टाइम हो जाएगा। निकोटिनिक एसिटाइल कोलिन रिसेप्टर, निकोटिनिक एसिटाइल कोलिन रिसेप्टर न्यूरोमस्कुलर जंक्शन में होता है ना, वो है लाइगैंड गेटेड आयन चैनल। लाइगैंड गेटेड आयन चैनल, इट इज पेंटामर, it is also called cis loop receptor and also called ionotropic receptor associated channel. Okay, so that's nicotinic acetylcholine receptor. Okay, next CNS का क्वेश्चन है, Identify this law. It utilizes power function of the stimulus. Power function of the stimulus. It is related to coding and decoding of sensory information. It describes the discrimination between intensities. खैर छोड़ो, मैं बता रहा हूँ, वो नोट डाउन करो. लास्ट टू लास्ट एग्जाम में वेबर फेशनर्स लॉ, उसके ऊपर क्वेश्चन आया था. सो प्लीज लिख लो. इंटेंसिटी डिस्क्रिमिनेशन इन द CNS, it is by Weber-Fechner's law and Stevens power law. दो इंटेंसिटीज, एक फाइन टच, एक हेवी टच, दोनों इंटेंसिटीज में डिस्क्रिमिनेट करने के लिए लॉ है. एक है वेबर-फेशनर्स लॉ और दूसरा है स्टीवंस पावर लॉ. आइडेंटिफाई दिस कंडीशन. एक्साइटेशन कॉन्ट्रैक्शन कपलिंग से रिलेटेड डिसऑर्डर. द आंसर इज मैलिग्नेंट हाइपरथर्मिया. मैलिग्नेंट हाइपरथर्मिया से रिलेटेड हर चीज पढ़ लो, क्योंकि इसके ऊपर एक ना एक क्वेश्चन FMG में जरूर आता है. सो प्लीज रीड इट. ओके, आइडेंटिफाई दिस प्रिकर्सर. सिंथेसाइज्ड बाय पिट्यूटरी बेसोफिल्स. इट एक्सप्लेन्स ACTH हैज MSH लाइक एक्टिविटी. अभी पढ़ने को टाइम नहीं है, मैं एक्सप्लेन कर रहा हूं वर्बली, आप सिर्फ सुनो, चाहो तो लिखो कुछ. एडिसन्स डिसीज नाम का डिसीज है, आपको पता है. क्या होता है उसमें? ग्लूकोकॉर्टिकॉइड्स कम हो जाते हैं. करेक्ट, ग्लूकोकॉर्टिकॉइड्स का डेफिशिएंसी हो जाती है. अब इसमें पिगमेंटेशन क्यों होता है? ये क्वेश्चन 2-3 बार FMG में आ चुका है. क्यों होता है? तो ग्लूकोकॉर्टिकॉइड्स अगर कम हो गए तो बाय निगेटिव फीडबैक ACTH के लेवल्स बढ़ते हैं. ACTH फ्रॉम द पिट्यूटरी, और ACTH हैज MSH लाइक एक्टिविटी. ACTH जो है इट हैज गॉट MSH लाइक एक्टिविटी, और इसलिए अपना एडिसन्स डिसीज में सर्कुलेटिंग ACTH लेवल्स हाई होते हैं, और वो ACTH को MSH लाइक एक्टिविटी है, मतलब मेलानोसाइट स्टिमुलेटिंग हार्मोन लाइक एक्टिविटी, जिसकी वजह से पिगमेंटेशन होता है. ओके, एक्सप्लेन व्हाई होल ब्लड इज नॉन न्यूटोनियन फ्लूइड. होल ब्लड इज अ नॉन न्यूटोनियन फ्लूइड, और उस इफेक्ट को कहा गया है फेरो-लिंडक्विस्ट इफेक्ट. ओके, दिस ऑर्गन, ये सब बेसिक क्वेश्चंस है. तो लार्जेस्ट सेल इन द बॉडी हम देख चुके हैं ऑलरेडी. इन्वॉल्व इन डिसोसिएटिव एनास्थीसिया ऑफ कीटामिन. हाँ, ये आपके काम का क्वेश्चन है. ये एक चैनल का नाम है, तो बताओ कि ये चैनल कौन सा है. इट इज इन्वॉल्व इन डिसोसिएटिव एनास्थीसिया इफेक्ट ऑफ कीटामिन. अब मैं देखता हूं, अभी तक देखा नहीं था, अब देखता हूं. बताओ कौन सा चैनल है इन्वॉल्व इन डिसोसिएटिव एनास्थीसिया इफेक्ट ऑफ कीटामिन. It is a voltage plus ligand gated channel. It causes calcium influx, and it is also involved in long term potentiation in hippocampus. तो बताओ कौन सा रिसेप्टर है ये? रिसेप्टर कह लो, चैनल कह लो. Anybody? I'm waiting. अरे ऑलरेडी डॉक्टर नाइस जी ने लिख भी दिया, NMDA रिसेप्टर. यस, दैट्स राइट. सो प्लीज रिमेंबर, NMDA रिसेप्टर फॉर ग्लूटामेट. NMDA रिसेप्टर फॉर ग्लूटामेट इज इन्वॉल्व इन लॉन्ग टर्म मेमोरी इन द हिप्पोकैम्पस. हिप्पोकैम्पस में लॉन्ग टर्म मेमोरी बसती है हमारी, और वहां पे चैनल कौन सा इन्वॉल्व है? NMDA रिसेप्टर फॉर ग्लूटामेट. ओके, तो ये है. इनक्रेटिन्स के बारे में पढ़ो. ये सब मैंने ऐसे ही निकाले थे आपको बताने के लिए. इनक्रेटिन्स आर रिलीज्ड बाय GI म्यूकोसा. जब आप ग्लूकोज खाते हो तो इन रिस्पॉन्स टू द ग्लूकोज दीज इनक्रेटिन्स आर रिलीज्ड एंड दे गो टू पैंक्रियाज एंड दे कॉज इंसुलिन सिक्रीशन. दीज आर कॉल्ड एज इंसुलिन इनक्रेटिन्स, और उनके नाम याद रखो, GIP and GLP-1. GIP and GLP-1. GIP क्या है? गैस्ट्रिक इनहिबिटरी पेप्टाइड. GLP-1 क्या है? ग्लूकागॉन लाइक पेप्टाइड. दीज आर कॉल्ड एज इनक्रेटिन्स. ओके, अभी आपका ग्लूकोज भी कम हो रहा होगा, तो मैं अभी ज़्यादा आपको स्ट्रेस नहीं देता. एक लास्ट 1-2 क्वेश्चंस लेते हैं, फिर आप खाना खाने को जाओ, क्योंकि बाद में आपका शायद मेडिसिन है. ओके, मेडिसिन है कि सर्जरी है? आई थिंक सर्जरी है ना. ओके, ठीक है. ये कौन सा प्रोटीन दिखाया है डायग्राम में? विच प्रोटीन इज शोन इन द डायग्राम? इट कनेक्ट्स Z line with the thick filament. Thick filament is anchored to the Z line by which protein? Largest known human protein is this. This is the largest known human protein. क्या है? कौन सा प्रोटीन है? Which is the largest known human protein which links Z line with the thick filament. Thick filament, उसको सार्कोमेयर में पकड़ के रखने वाला प्रोटीन, तो उसका नाम है टाइटिन. तो ऐसे अभी ये सारे क्वेश्चंस मैं आपको यहाँ लिंक में भेज रहा हूँ. तो अभी आप जाओ, खाना खाओ और सर्जरी के लिए प्रिपेयर हो जाओ. अगला जो चैप्टर है वो सर्जरी है. तो थैंक यू वेरी मच फॉर अटेंडिंग. और 2 चीज़ें मैं आपको यहाँ लिंक में पोस्ट कर रहा हूँ. एक तो एक्चुअली मैंने बहुत सारे क्वेश्चंस लाए थे मैराथन सेशन के हिसाब से, बट एज यू नो कि थोड़ा सा लेट भी शुरू हुआ है, तो हमारे पास टाइम कम रहा है. जो भी मेरे पास मटेरियल है जो आपके FMGE के लिए मैंने निकाला हुआ है, वो मैं लिंक में पोस्ट कर रहा हूँ. आप बस उसके ऊपर फोकस करो. फिजियोलॉजी आपका MCQs निकल जाएंगे उससे. ओके, सो थैंक यू वेरी मच. बाय बाय, सी यू एंड ऑल द बेस्ट. ओके, ज़रूरत पड़ी तो एक बार और मिलेंगे बाद में. थैंक यू.
Hi guys, good evening, good evening. Can you all see me? Can you all hear me? Can you all see me? Can you all hear me? Quick feedback, quick feedback. All right, so today we will be completing the entire surgical marathon. We'll start up from a basic component. This is a workbook that we have created. Yes, guys. Hello, hello. Good evening. है ना? चलो. So we'll start with the basic objective of identifying what your important exam images are and then what are the points that you're going to ask. The first one is going to be simple spotters. In the spotters, you'll get an image like this. Now, if you get an image like this is what we call it as a corrugated drain. I've already given the text so that you don't need to worry about it. I want you to sit back, relax, enjoy, and remember. I hope the audio is clear, guys. Everybody's able to hear. A thumbs up. Good to see you guys too. ओके चलो सो व्हेन वी टॉक अबाउट द स्पॉटर्स देखो अगर कभी भी आपको कोई ऐसा प्लीटेड शीट दिखता है ठीक है इफ दिस इज ऑरेंज इन कलर येलो इन कलर इसका मतलब वो लेटेक्स है तो मटेरियल लेटेक्स हो गया ठीक है नाम कॉरुगेटेड ड्रेन हो गया मटेरियल लेटेक्स है दिस इज कॉल्ड एज एन ओपन ड्रेन देखिए ड्रेन्स ना दो टाइप के होते हैं ओपन और क्लोज्ड इफ यू गोइंग टू कलेक्ट इट इन अ कंटेनर इट विल बिकम अ क्लोज सिस्टम अगर आप उसको छोड़ दोगे ओपन तो वो ओपन ड्रेन है यहाँ पे आपको कंटेनर दिख नहीं रहा है तो ये आपका ओपन ड्रेन है एज सिंपल एज दैट ठीक है फिर बारी आती है कि इसको आप कोई कुछ कर रहे हो टू सक द ड्रेन आउट द आंसर इज नो वो अपने आप डिपेंडेंट स्टेटस से गिर रहा है तो आप बोलोगे ये पैसिव ड्रेन है ना सो नॉर्मली देखिए ड्रेन्स ना व्हेनेवर वी टॉक अबाउट इट द टू टाइप्स ऑफ ड्रेन नंबर वन इज गोइंग टू बी एन एक्टिव ड्रेन अनदर वन इज अ पैसिव ड्रेन एक्टिव में नेगेटिव प्रेशर लगता है सक्शन प्रेशर लगता है पैसिव में कुछ नहीं लगता पैसिव इज बेसिकली गोइंग टू बी बिकॉज ऑफ द डिपेंडेंट स्टेटस या तो ग्रेविटी की वजह से ड्रेन करता है या डिफरेंस इन प्रेशर जैसे अगर एब्डोमेन और एटमॉस्फेयर में देखोगे यू हैव मोर प्रेशर इनसाइड द एब्डोमेन सो हाई प्रेशर टू लो प्रेशर ड्रेन करेगा उसको कैपिलरी ग्रेडियंट प्रेशर बोलते हैं ठीक है फिर दूसरा आता है कि ओपन सिस्टम ड्रेन या क्लोज सिस्टम ड्रेन पैसिव और एक्टिव ड्रेन्स दोनों ओपन नहीं देखो व्हेन यू टॉक अबाउट द होल कॉन्टेक्स्ट ऑफ इट एक्टिव ड्रेन्स कैन नॉट बी एन ओपन ड्रेन्स क्योंकि उसके लिए सक करने के लिए यू नीड अ क्लोज सिस्टम है ना तो कंटेनर वाइज इट इज गोइंग टू बी अ क्लोज पैटर्न तो यही आपका बेसिक ऑब्जेक्टिव है राइट सो दिस अ कॉरुगेटेड लेटेक्स ड्रेन व्हिच इज ओपन फिर ये आपका एक और ड्रेन है दिस योर प्रीवियस एग्जाम क्वेश्चन आल्सो इफ यू सी अ प्लेट ऑफ रबर दिस इज व्हाट वी कॉल्ड एज अ पेनरोज ड्रेन इट इज आल्सो अगर येलो कलर में देखोगे तो लेटेक्स है there is no container it is open and it is also going to be on a passive system so this is also going to be a passive drain फिर same corrugated drain का एक और extended version और नया version you can say it this is basically transparent तो silicon based है तो silicon biologically inert होता है इसको body में आराम से लगा सकते हो latex ज़्यादा react करता है this is better this is also a corrugated drain क्योंकि ये ट्रांसपेरेंट है इसको आप सिलिकन बोलोगे ये आपका मोस्ट इंपॉर्टेंट ड्रेन सिस्टम है जब आप एग्जाम में पूछोगे राइट नाउ दिस ड्रेन सिस्टम इज व्हाट वी कॉल्ड एज द रोमोवैक ड्रेन ऐसे इसको पकड़ के दबाओगे तो नेगेटिव सेक्शन क्रिएट होता है तो दिस इज गोइंग टू बी एन एक्टिव ड्रेन एंड दिस इज अ क्लोज्ड सिस्टम ड्रेन दिस इज अ क्लोज्ड सिस्टम ड्रेन इससे कंफ्यूज नहीं हो रहा वैक से ठीक है वैक क्या है वैक्यूम असिस्टेड क्लोजर व्हिच इज आल्सो कॉल्ड एज नेगेटिव प्रेशर वुंड क्लोज सिस्टम उसकी इमेज हमारे पास आगे है दैट इज गोइंग टू बी ओनली फॉर वुंड्स एंड दैट इज गोइंग टू बी पुट एट -125 मिलीमीटर ऑफ मर्क्यूरी प्रेशर ये आपके कैविटीज में लगता है सरफेस वुंड पे नहीं लगेगा फिर ये आपका आ गया फोलीज कैथेटर right this is what we call it as the Foley's catheter or also called as the self retaining rubber Foley's catheter this is your Foley's catheter फिर आपसे एग्जाम में पूछ रहा है कि भाई Foley's catheter के कलर कोड और उसका ये बता दो ठीक है तो इसका निमानिक क्या है याद रखने के लिए याद रख लो गोरी जो है वो वेरी ब्यूटीफुल है ठीक है गोरी है तो वेरी ब्यूटीफुल है इट इज द स्टिग्मा नॉट ऑलवेज इंपॉर्टेंट ठीक है गोरी मीन्स वेरी ब्यूटीफुल right now the word G stands for green yeah I got it guys I'll use it both English as well as Hindi I'll try to keep it predominantly in English as well now G stands for green which is going to be a 14 French catheter O is orange which is 16 French R is red which is 18 Y is yellow which is 20 V is violet which is 22 B is blue which is 24 French फिर question आता है what is this French what is this French remember French is the outer diameter so look at the lumen when you look at the lumen The lumen precisely has two distinctive diameters, the inner diameter and the outer diameter. This is what we call it as the inner diameter, and this is what we call it as the outer diameter. The outer diameter of the tube is what we call it as fringe. The outer diameter of the tube is what we call it as fringe. This is what we call it as fringe. The screen is almost at its brightest beta. Clear? I think it is, yeah, it's already at its brightest. Sure. Now you will see another one which is called as, you can see the orientation is like a T-tube. This is called as a T-tube catheter. It is again transparent silicon. It is used for CBD repair and surgery. When do you remove the T-tube? It is going to be 10 to 14 days. Then you'll see another image which is called as a three-way Foley's catheter. We call it as three ways because distinctly there are three distinct ways that are present, right? Now the first one that you can see, it is for balloon inflation. So there's a balloon inflating channel. Second, which is the widest one, this is to collect urine. And the third is from where you send for irrigation. So whenever you do any bladder surgery or urethral surgery, for bladder and urethral irrigation, you will use a three-way Foley's catheter. So I've written clearly it is used for bladder as well as urethral surgeries. Then you see a catheter which is going to coil on itself. It is called as a pigtail catheter. Remember, pigtail catheter is usually confused with a double J stent, which is called as a DJ stent, right? So DJ stent will have coiling on both the ends, right? It is coiled on both ends, whereas pigtail catheter will have coil only at one particular end. It will have coil at one particular end. That's it. That's the difference. Then comes your nasogastric tube. Again, very, very important from our exam perspective. The nasogastric tube is also called as the Ryle's tube. The average length of the Ryle's tube is going to be 100 centimeters. It is used to decompress the stomach as well as if you are looking to feed the patient for if the feeding requirement of the patient is less than 2 weeks. If the feeding requirement is less than 2 weeks, you can go with Ryle's tube. If the requirement of feeding is more than 2 weeks, then you have to look for feeding gastrostomy or a feeding jejunostomy, right? So with Ryle's tube, you can only feed for or maximum until 2 weeks. That is going to be considered. Now, another question that they ask you is, how do you measure the adequate length of the Ryle's tube to be inserted? That's your previous exam question. So, to measure the adequate length of nasogastric tube. To measure the adequate length of the nasogastric tube that you have to insert, we standardly call it as the Neck's rule. We call it as the Neck's rule. Now, what is this Neck's rule, right? So, if you look at this, a representation of the patient. This is the neck. This happens to be the thorax and the abdomen. And let's say this is where you have the Ziffy sternum. This is the suprasternal notch. This is the sternum. And let's say this is the Ziffy sternum that is there. Right? So what is the next rule is, if you look at the orientation, you take the Ryle's tube from the tip of the nose to the earlobe, from the tip of the earlobe to the Ziffy sternum. You measure the length. This is called as Neck's rule. Right? So next rule is to, after you have measured, this is the amount of nasogastric tube that you have to flush it inside the patient. This is what we call it as the standard Neck's rule. So nose to earlobe, earlobe to Ziffy sternum is what we call it as the Neck's rule. Next comes a very important tube that is present. This is what we call it as the SBT tube, or also called as the Sengstaken-Blakemore tube. Now in the Sengstaken-Blakemore tube, as you can see, there will be 3 channels and 2 balloons, right? So there are channel number 1, channel number 2, channel number 3. So 3 channels and there are 2 balloons. This is balloon number 1 and this is balloon number 2. The balloon number 1 is what we call it as the esophageal balloon. This is what we call it as the esophageal balloon. The balloon number 2 is what we call it as the gastric balloon. This is what we call it as the gastric balloon. Right. Now, remember, these are usually used to control the bleeding from the bleeding esophageal varices. Esophageal balloon will be inflated with 40 millimeters of mercury pressure, and I will use air to inflate it. The gastric balloon will be inflated with 300 ml of air, and again inflated in the same context, right? Now, when you use a Sengstaken-Blakemore tube, as we have said, it is controlling the bleeding from the bleeding esophageal varices. One of the most important thing to be evaluated or to be remembered in a Sengstaken-Blakemore tube is that you have to deflate the balloon every 12th hourly. The reason why you have to deflate the balloon every 12th hourly is if you don't deflate it, it will cause pressure-induced necrosis. So, preventing pressure-induced necrosis, you have to deflate the balloon every 12th hourly. Now, this was the exam which was asked in your previous NEET PG, and this image is what we called as the Sengstaken-Blakemore tube. Now, Sengstaken-Blakemore tube, sorry, this is the Sengstaken-Blakemore. This is your Jackson-Pratt drain. There's a misprint here. This is your Jackson-Pratt drain. This is your Jackson-Pratt drain, right? Now, in a Jackson-Pratt drain, you have a balloon that is present. And then you have a fenestration and the catheters that are going to follow, right? Then you have the fenestration and the catheters which are going to follow. Again, it's a negative suction drain. So, Jackson-Pratt drain, it is a closed system. It's a closed system active drain. The Jackson-Pratt drain is a closed system active drain, and that is your Jackson-Pratt drain, right? So, Sengstaken-Blakemore tube we have already discussed on top. So, there's a misprint here. So, I'm just going to hide this off. So, this is a Sengstaken-Blakemore tube. Now, next is your color code cannula and the flow rate that is going to be present, right? So, when you look at the whole color code system, I've given you a small mnemonic to remember. The core of the earth is made up of lava. Lava is going to be orange in color. Then the soil is going to be gray. Then you have the green trees. Then you have the pink flower. You have the blue sky. You have the yellow sun. And you have the violet universe. If you don't believe that the outer one is universe, I can put some stars for you so that you can remember. Right. So, this is with respect to the cannulas in the color code system. Now, when you look at this, orange is going to be your 14 gauge. It is going to be 14 gauge. Gray is 16 gauge. Green is 18 gauge. Pink is 20 gauge. Blue is 22 gauge, yellow is 24 gauge, and 26 is going to be violet. That is the color code system that you have, right? Now, usually they ask you how much is the flow rate. When you talk about the orange, it is 240 ml per minute. Gray is going to be 180 ml per minute. Green is going to be 90 ml per minute. Pink is going to be 60 to 65 ml per minute. Blue is going to be 30 ml per minute. Again, 30 to 35 ml per minute. 30 to 35 ml per minute. Yellow is 20 ml per minute. And violet is going to be 12 ml per minute. Violet is going to be 12 ml per minute. These are all the color codes and the flow rates. Next comes your minimal invasive surgery laparoscopic instruments. Again, your exam question. They simply ask you to identify the instruments. If it is hollow, it is going to be port. If it is solid, it is going to be trocar. Trocar will always have the sharp tip, and that's your exam point, right? The trocar will always have the sharp tip. Now, the question is, during the port placement, if the vessel is injured, what do you do? Remember, keep the needle or the port in situ and convert it into an open and explore. So, you'll convert this into open and then you're going to explore, right? Now, what is the next image that you can see here? This is the image number 2. The image number 2 is what we call it as the lens. It is the lens. Image number 2 is what we call it as the lens. And the most common lens that we are going to use is going to be 30 degrees. The angle of the lens that we are going to use more commonly, it is going to be a 30-degree lens. It is going to be a 30-degree lens, right? Now, when you talk about the ergonomics, whenever you're inserting the instruments, you have the camera, which is the optical, and then you have two working ports which are present. The angle between the optical and The working port is what we call it as the azimuth angle. They've asked you in your NEET PG, what is azimuth angle? Azimuth angle is the angle between the camera and the working port. How much will be the azimuth angle? It is 30 degrees. Angle between the two working ports is what we call it as the manipulating angle, which is 60 degrees. Angle between the instruments and the body is what we call it as elevating angle. That is also going to be 60 degrees. And that's your exam question. Now, this was also your previous exam question. They've asked you the image where you can see there is a blunt trocar. There is a blunt trocar which is atraumatic, and this blunt atraumatic trocar is what we call it as the Hansen's port. This is what we call it as the Hansen's port. Now this was your repeat exam question. They've asked you multiple times. What is this? This is your Veress needle. This happens to be your Veress needle, right? This happens to be your Veress needle. Now, when you look at the Veress needle, what is the objective of Veress needle? It helps to create pneumoperitoneum. The most common gas used is carbon dioxide. The initial flow rate is going to be 1 to 4 liters per minute. And the maximum flow rate is 20 liters per minute. The intra-abdominal pressure to be maintained as 12 to 15 millimeters of mercury. It is going to be 12 to 15 millimeters of mercury. This is the pressure that is supposed to be maintained. Your previous exam question is, if there is a previous laparotomy scar, if there's a previous laparotomy scar, then where would you put the Veress needle? That is going to be on your palmos point. What is the palmos point? It is the left subcostal. That's the left subcostal in the mid-clavicular line is what we call it as the palmos point. Now, usually they ask you two more questions. What is the direction in which you would like to insert? Now, remember, it should always be pointing towards pelvis while inserting. It should always be pointing towards the pelvis while inserting. That you have to make sure that is going to happen, right? Next, you have the energy devices. In the energy devices, you have the monopolar, bipolar, you have the harmonic and the thunderbeat. Remember, you will see their ability to cut, coagulate and all that. So the first thing, the electrical component, the energy that you are going to use, right? In monopolar, we use electrical energy. In bipolar, we use electrical energy. In harmonic, we don't use electrical energy. We are going to use the vibrating energy. Whereas in thunderbeat, I'll be using both electrical and vibrating energy together. So this is called as the combined energy source. This is what we call it as the combined energy source. This is what we call it as the combined energy source, right? Now, we'll see their ability to cut, coagulate and seal. The monopolar can cut, it can coagulate, it does not have the ability to seal. The bipolar cannot cut, it can coagulate, it cannot seal, it can only coagulate, no sealing property also, right? When you talk about the harmonic scalpel, it is considered to be as the safest energy device in a patient with pacemakers, because those patients who have pacemakers, if you use an electrical energy or electrical device, it interferes with their pacemaker setting, right? So in order to prevent that, I'll be using harmonic scalpel, which does not have any electrical impulses. Hence, it is not going to interfere with any of the following components, right? They'll ask you what is the vibrating frequency, that is 20 to 50,000 hertz. It can cut, it can coagulate, it can seal, as well, right? The same for thunderbeat also, it can cut, it can coagulate, it can seal. They'll ask you what is the size of the vessel it can seal. Remember, the maximum size of vessel that they can seize is 7 millimeters in diameter. The size of the vessel that it is able to seal is around 7 millimeters. It is going to be approximately 7 millimeters, right? Then they'll ask you what is the difference between a cut and a coagulating current. Remember, in a cut current, if you plot the graph between voltage and frequency, you will have low voltage but high frequency. In a coagulating current, you see the high voltage but the repetition is less, there's a low frequency. So high voltage with low frequency is what you will see in your coagulating current. Now you have the suturing rule. That is again an important topic from the exam perspective. Right. So when you look at the suturing rule, the first question, what is the length of the suture material? How do you calculate the length of the suture material? It should be 4 times the length of the wound. It should be 4 times the length of the wound. The depth of the wound, it is going to determine, I've mentioned it here, the depth of the wound, it is going to determine the entry and the exit of the wound, and also determine the distance between the two sutures, right? The angle between the needle and the skin at the entry point has to be 90 degrees. This is your previous exam question. Distance between two sutures should be twice the depth of the wound. It should be twice the depth of the wound. It is twice the depth of the wound. The length of the suture here is the suture material that is left behind after putting a knot. This is approximately 1 to 2 millimeters. The length of the suture here is approximately 1 to 2 millimeters, right? So this is with respect to suturing rule. Then you have the suturing techniques, right? If it is starting from one point ending at the other, it is simple continuous. If there are 2 pricks on either side and it is going to end, this is called a simple interrupted. If there are going to be 2 pricks on either sides, and then the knot is there, but if it is, see, this is the line of the wound, this is the line of the suture, if they're perpendicular to each other, it is vertical, and if they're parallel to each other, they are going to be horizontal mattress, and if it does not come onto the surface, it is subcuticular, and it is the best cosmetic. This is the best cosmetic outcome. The best cosmetic outcome is going to be seen in your subcuticular sutures. It will be seen in your subcuticular sutures. Then you have the knotting techniques. If you have a single loop, this is called as half hitch, it is highly unstable. If you have 2 loops, it is called as granny's knot, which is unstable. Similarly looking is your reef or a square knot, which is considered to be stable. What is the difference? So when you look at the granny's knot, in the granny's knot, this is the loop you can see. One thread is going under the loop, one thread is going over the loop. So one thread here also you can see this is the red loop. Green thread is going under, this green thread is going over. So agar ek thread upar or ek thread niche se ja raha hai, right? One above and one below. This is what we call it as the granny's knot. In a square or a reef knot, you take this as a loop and you see both the threads are going under the loop or both the threads are going over the loop. Agar dono threads niche se ya dono thread upar se ja rahe, this is called as reef or a square knot. It's an absolutely stable knot. Then you have the surgeon's knot, which is more stable. When you look at the surgeon's knot, there are 2 loops on bottom, 1 loop on top, and you will see the same context here. You will see that this will also have the reef pattern. This will also have the reef pattern. So when you look at this, just for sake of understanding, let's say this is the green loop that you have, and here you see the red thread is going over the green loop. Here also the red thread is going over the green loop. Now you consider this as the red loop, and here you see the green thread is going over. Here also the green thread is going over, right? So if both the threads are either going under or over, this is what we call it as squaring. And if you have 2 loops on top, bottom and 1 loop on top, this is what we call it as the surgeon's knot. This is what we call it as the surgeon's knot, right? Next is the suture removal period. That also be in your previous exam question. Now, when you look at the suture removal period, for face, it is 3 to 5 days. For scalp and arms, it is going to be 7 to 10 days. For trunk, legs, hands and feet, it is going to be 10 to 14 days. Palms and soles is longest, that is your 14 to 21 days. (10 to 14 days), and then palms and soles is longest, that is your 14 to 21 days. So 14 to 21 days. Now, another repeatedly asked exam question is your pressure sore, bed sore, also called as decubitus ulcer. The criteria is whenever the pressure exerted is more than the capillary occlusive pressure, which is around 30 millimeters of mercury, the patient is more likely to develop a pressure sore. The risk factor is prolonged immobilization, bedridden or a wheelchair status. The most common site is going to be ischium, followed by greater trochanter, followed by sacrum. Right. Now, they'll usually ask you based upon the categorization. I've already given you a table. If there is only erythema, which is non-blanching, it is grade 1. If there is a partial thickness skin loss, it is grade 2. A full thickness skin loss where the subcutaneous fat is exposed is grade 3. If the underlying structure is involved, like a muscle, a vessel, a tendon, and nerve, it is called as grade 4. Right. For grade 1 and grade 2, we will go only with conservative line of management. For grade 1 and grade 2, It is conservative line of management where you give water, air, bed, frequent change in position, and skincare. If they ask you in frequent change of position, how frequently should you change? If a patient is bedridden, then it is every second hourly. It is second hourly. If the patient is wheelchair bound, if a patient is wheelchair bound, for a wheelchair bound patient, you have to change it every 10 minutes. For a bedridden patient, change it every second hourly. For a wheelchair patient, change it every 10 minutes, right? For grade 3 and grade 4, for grade 3 and grade 4, number 1, cleaning and debridement, and put the patient in negative pressure wound closure system, which is also called as VAC. And this is your previous exam question. The VAC is an old term. We don't use it any longer. VAC stands for vacuum assisted closure. Now, in the VAC, what are the pressures we maintain? That is at minus 125 millimeters of mercury. Intermittent pressure, increase the granulation tissue, clears the secretions, and you need to change the dressing once in every 5 days. Unlike any other wound dressing, you don't need to do dressing every daily basis, right? Next is your burns. In the burns, important points that they will ask you. Number 1, what is the most common rule used? That is called as the Wallace rule, also called as rule of 9. I hope everybody knows the rule of 9. I'm not going to go into greater details into it, but you should know that what is the definition of a trunk. So every time we say trunk is chest plus abdomen. It is going to be chest plus abdomen. So that is the first point. Difference between the child and the adult. So when you look at what is the difference between a child and the adult, that is the number 1 is the head and neck. When you look at the head and neck in total, we say adult is 9%, child is going to be 18%. Next is your perineum. Perineum in adult will consider as 1% and perineum is not calculated in child. Then comes the lower limb. Lower limb in adult, it is going to be 18%. In child, it is going to be 14%. That's the only difference that you should be aware of, right? Now, this table is quite important from our exam perspective. This is about the classification of the burn wounds based upon the extent and the depth. Okay? So, now, when you talk about the first degree burn, in a first degree burn, you see there is only the epidermis is going to be involved. Second degree superficial, there is going to be papillary dermis. Then you have the reticular dermis. Third degree is full thickness of the skin. And fourth degree is involvement of underlying structure. Involvement of underlying structure. Involvement of underlying structure. Right? That's your components here. Now, wherever you have skin, you will have pain. So, first degree will have pain. Second degree will have superficial will have pain. Second degree deep will not have pain, but there is something called as pin prick sensation that is present. No skin, no pain. Blisters are actually a telltale sign of secondary superficial. The first degree and second degree may or may not have blister. No skin, no blister. So here no blisters. In the first degree, there is presence of erythema. Secondary superficial, it is bright red in color. Secondary deep, you will see it is going to be mottled pink or waxy white. Third degree is your leathery in appearance. Fourth is like a charcoal, that is charred. The first degree, second degree superficial, second degree deep will heal. These two will not heal. There is no scar in these two. The scar will start developing from here on. Eschars are usually formed from secondary deep onward. They are more predominant. Right. Now, if they ask you how do you resuscitate, earlier we used to have a formula called as Parkland. Parkland is obsolete, so we don't use it any longer. We all know the fluid of choice is going to be for burn resuscitation is going to be the ringer lactate. It is going to be ringer lactate. We are going to follow the ATLS protocol. I've already given it to you. Just for your own revision sake, just go through the ATLS protocol for fluid management. Usually we say that, again in a quick recap, if it is a second degree, third degree burn, and if it is an adult, you give 2 ml per kg per percentage of total body surface area burnt. If it is a child, we give 3 ml per kg per percentage of total body surface area burnt. If it's a fourth degree or an electric burn, let it be an adult or a child. Then it is going to be 4 ml per kg per percentage of total body surface area burnt. Right. So this is in the context of the fluid of choice. Right. Now, when you talk about the colloids, the most commonly used colloid for resuscitation in burns is HAS, that is human albumin solution. Ideal time to administer is after 24 hours of burns. Muir and Barclay formula that we use is 0.5 into weight in kilograms into percentage of total body surface area burnt. What is the protocol for administration? We divide them on a 12th hourly basis for administration. In the first 12 hours, you can administer every 4th hourly. So you can give 3 portions. Then after you can give every 6th hourly. So next 12 hours is 2 portions. And from thereafter, every 12th hourly. So this is the protocol for resuscitation. In the burn wound management, they'll ask you the topical agents that we prefer. Normally, we'll try to address it against the Pseudomonas, gram-negative, eschar, and the particular side effects. Silver sulfadiazine is extremely effective against Pseudomonas and gram-negative bacteria. It cannot penetrate eschar. So, if there is an eschar, these agents will be useless. You have to peel the eschar, and then only you will be able to put it across, right? There is no specific side effects. 0.5% silver nitrate has good action against Pseudomonas, decent action against gram-negative. Again, it cannot penetrate eschar. It results in blackening of skin. So hence not preferred. Mefenide acetate has got little action against Pseudomonas gram-negative, but it can penetrate eschar. It can penetrate eschar. The problem with mefenide acetate is, number one, it causes metabolic acidosis. And number two, it causes increased pain on application. It causes excessive pain on application. Next comes the silver sulfadiazine with cerium nitrate. So you have silver sulfadiazine with cerium nitrate. This is misprint here. This has got excellent action against Pseudomonas gram-negative. It can penetrate eschar also. It can penetrate eschar. Now, as it can penetrate eschar and it has got no side effect. So, if you look, what is the most common topical agent? It is silver sulfadiazine. But if they ask you which is the best topical agent, the best topical agent is your silver sulfadiazine with cerium nitrate. It is your silver sulfadiazine with your cerium nitrate. So that's in the context of burns. Then in the thyroid, we have something called as the optimum cytology criteria. This was our previous exam question also. So we're quickly looking at it. The size of the needle required here is 22 to 26 gauge needle. Single best answer is going to be 23 gauge needle. There should be 2 aspirates, 6 follicles and 10 to 15 cells per aspirator. If this is satisfied, then you can say the optimum cytology criteria is satisfied, right? In a comparative table about the inflammatory thyroid swellings, very important. You have 3 important components that we would like to compare. So we have the Hashimoto's, decurvents, and the renal thyroiditis. Now, type of inflammation. When you talk about the Hashimoto's as well as renal, they are chronic. Decurvents is subacute inflammation. It is your subacute inflammation, right? Now look at the etiology. Hashimoto's is autoimmune. Decurvents is post-viral upper respiratory tract infection resulting in cross-reacting antibodies. Renal is predominantly idiopathic. It can also be autoimmune as well. Now, when you talk about the pathophysiology of Hashimoto's, basically there is an anti-TPO antibody that is formed, and that thyroperoxidase is inside the follicular cell. To damage that follicular cell, you will go for CD4 cell activation, which got CD8 cells activation, because cytotoxic T cells. Now, these cytotoxic T cells will result in follicular disruption. Whereas here in decurvents, there's a cross-reacting antibody that are formed after a post-viral infection. These antibodies will consider follicles as foreign. They'll go attack them. So these cross-reacting antibodies will irritate the follicles. Usually for renals, it is idiopathic or unknown. Sometimes it can be associated with IgG4 class of antibodies. Remember, the IgG4 class of antibodies is also associated with the hormones disease, that is your retroperitoneal fibrosis, and is also associated with autoimmune pancreatitis, right? The HLA which are associated with this is, with Hashimoto's, there are 3 HLAs. HLA B8, DR3 and DR5. It is HLA B35. There is no specific HLA in your decurvents thyroiditis, right? All these disorders are more common in females, needless to tell you. Hashimoto's is seen in relatively younger age, that is 30 to 40. Renal is seen after age about 50. Whereas your decurvents can be seen at any particular age group, right? When you look at Hashimoto's thyroiditis, the patient's presentation would be of thyroid swelling with signs and symptoms of hypothyroidism. Signs and symptoms of hypothyroidism. There is signs and symptoms of hypothyroidism, right? Whereas in decurvents, it is a midline neck fullness with pain on swallowing. In Hashimoto's, there is, in renal thyroiditis, there is a massive midline neck swelling. There's a massive midline neck swelling associated with pressure symptoms and hypothyroidism. Associated with pressure symptoms as well as hypothyroidism is there. When you look at the thyroid status in your Hashimoto's thyroiditis, initially it will be hyper. There is no intermediate. Eventually it will be hypo. Here immediately it will be hyper, intermediate hypo, but eventually becomes euthyroid because the self-limiting condition. Renals, you will see all 3 of them will remain hypo only. Investigation is almost same. Here also you do an ultrasound with thyroid function test. Here we do an ultrasound with thyroid function test with FNSC, because renal thyroiditis most likely differential diagnosis anaplastic cancer. To rule out anaplastic cancer, you are going to do a FNSC here. How would you like to manage? Now, the management for inflammatory thyroid swellings, you cannot operate, because when you try to operate, you will cause more damage or more injury than actually the benefit, right? So here for Hashimoto's and decurvents, I will start lifelong thyroxine. Whereas when you talk about decurvents, decurvents is a self-limiting condition. You don't need to do anything. Hashimoto's and renals, they are chronic disorders. They causes fibrosis. For these patients, you cannot afford to lose it down. You have to make sure that you give them lifelong thyroxine, right? If you try to operate, it will cause more harm than the benefit. Henceforth, surgery is not preferred here. Decurvents are usually not associated with pressure symptoms. Decurvents are usually not associated with pressure symptoms. See? Chal. Now, quickly looking at the components of the thyroid cancer as well. Now, when you look at the thyroid cancer, we have papillary, follicular, anaplastic, and medullary. Remember, overall, most common thyroid cancer is going to be your papillary, and the origin is going to be from the follicles. The most common thyroid cancer in ectopic thyroid gland is your follicular cancer thyroid. Worst is anaplastic, whereas medullary cancer thyroid is associated with MEN syndrome. It is originating from C cells, right? So, when you look at the papillary is follicle origin. Your follicular and anaplastic is also follicular origin. They are also follicular origin. So when you look at by incidence, I can say overall most common is papillary cancer thyroid. Most of them, I mean almost all of them are more common in females, right? The usual age of presentation that you see for papillary cancer thyroid, you will see relative to younger age, that is 30 to 40 years. Follicular cancer is between 40 to 50 years. Anaplastic is seen in age above 50 years. If it is medullary cancer thyroid, which is sporadic, that is for general population, it is seen in age above 50 years. If it is associated with Men's syndrome, it is seen in age under 20 years, right? Now, as we all know, all these are more common in females when compared to males. All these are going to be more common in females when compared to males, right? Remember, the gene associated with papillary cancer thyroid is going to be BRAF, whereas follicular cancer thyroid is PTEN, and medullary cancer thyroid is going to be RET gene mutation. It is going to be the RET gene mutation. The risk factor for papillary, again they've asked you again and again, that is radiation exposure, thyroglossal duct cyst, and Hashimoto's thyroiditis. Hashimoto's is considered to be questionable, but the other two are absolute risk factors. For follicular, it is long-standing untreated goiter. There is no specific risk factor for anaplastic. Mentor syndrome is associated with your medullary cancer thyroid, right? Clinical features, just to get a distinctive outline. Papillary will present a solitary thyroid nodule with cervical lymphadenopathy. Follicular cancer thyroid will be thyroid swelling with pulsatile forehead bony swelling. The reason there's a pulsatile forehead, the reason why you have a pulsatile forehead bony swelling, that is because of osteolytic secondaries which are going to be from the follicular cancer thyroid. Anaplastic, it is almost like Riedel's, massive swelling, huge pressure symptoms. So massive midline neck swelling with severe pressure symptoms will be there. Medullary cancer thyroid with solitary thyroid nodule with diarrhea. The diarrhea is because of 5-HT3 that is secreted, that is the serotonin. The effect of serotonin on the GI mucosa, it stimulates the GI mucosa, and that stimulation of GI mucosa will result in development of diarrhea, right? The mode of spread for papillary cancer thyroid, it is going to be lymphatics. Your follicular is hematogenous, anaplastic is direct, whereas medullary is both lymphatics as well as hematogenous. The most common site for secondaries. The most common site for secondaries for papillary cancer thyroid is lungs, whereas for follicular it is bones. For your anaplastic, it is again lungs, whereas in terms of your medullary, liver followed by bones. Now, as you can see, there are two bony secondaries which are present here. Follicular, most commonly it is associated with osteolytic secondaries. It is your osteolytic secondaries. Medullary cancer thyroid most commonly will have osteoblastic secondaries. It will have osteoblastic secondaries. It will have the osteoblastic secondaries. Now, for all malignancies, the investigation is ultrasound, thyroid function test, FNSC, thyroglobulin, which is a tumor marker. Remember, in follicular cancer thyroid, FNSC cannot differentiate. It cannot differentiate between follicular adenoma and follicular carcinoma. The only way you can see is presence of capsular and vascular invasion. So, capsular invasion and vascular invasion has to be assessed. Just for the sake of understanding, if I simply say difference between follicular adenoma and follicular carcinoma, there is no capsular vascular invasion. Follicular carcinoma will have both capsular as well as vascular invasion. So such patients, we take the patient for lobectomy with frozen section. So investigation of choice here is going to be lobectomy with frozen section. We take the patient for lobectomy with frozen section. Whereas here it is again anaplastic is same, ultrasound, thyroid function test, FNSC as well as thyroglobulin. Medullary cancer thyroid will also have same, that is ultrasound, thyroid function test, FNSC. But tumor marker here, it is going to be CEA, that is calcitonin will be elevated. CEA and calcitonin are the tumor markers which are elevated in your medullary cancer thyroid. Now, when you look at the presentation of HP, you'll see orphan ani nuclei and orphan ani nuclei will be there. There will be presence of samoma bodies. Samoma bodies are like these onion peels that you can see here, right? These are your samoma bodies. Samoma bodies are nothing but an example of dystrophic calcification. So what is samoma bodies? Samoma bodies are nothing but dystrophic calcification. The other conditions that you can see samoma bodies can be remembered by a small mnemonic, that is your PSM. That is your papillary variant of RCC will also have it. Serous adenoma of the ovaries. It is the serous cyst adenoma of ovaries. M stands for meningioma. M stands for meningioma, right? So papillary variant of RCC, serous adenoma of ovaries, as well as meningioma. These are the components that you will see. Whereas in follicular cancer thyroid, you will see the Ashkenazi cells. So you have the Ashkenazi cells as well as the oxyphilic cells. The Ashkenazi cells, the oxyphilic cells, and the Hurthal cells. All these will be seen in your follicular cancer thyroid. These amyloid strands, it is specific. You can see these strands which are going into, these are your amyloid strands. Presence of amyloid strands indicates it is your medullary cancer thyroid. It is your medullary cancer thyroid. Then you have MEN syndrome. We have divided into MEN1, MEN2A, MEN2B, and the MEN4 syndrome. Now MEN2A is now called as MEN2 syndrome. MEN2B is called as MEN3 syndrome, and you have MEN4 syndrome, right? Now, when you look at this, MEN1 is also called as the Buerger syndrome, which will have pituitary adenoma, parathyroid, and pancreatic adenoma. It is the pancreatic adenoma. Then you have Sippel syndrome, that is MEN2A, that is parathyroid adenoma, medullary cancer thyroid, and pheochromocytoma. MEN2B is mucosal neuroma, medullary cancer thyroid, pheochromocytoma, along with that marfanoid habitus. MEN4 is reproductive organ tumors with MEN1 syndrome. So all the tumors that you have in MEN1, along with that, if there's a reproductive organ tumors, it is called as MEN4 syndrome. This is called as the MEN4 syndrome. So this is about the MEN syndrome. Right? So that's all in all with respect to the thyroid. We'll talk about the breast next. Now, in the breast, repeatedly they have asked you about the BI-RADS. BI-RADS is a breast imaging reporting and data system. So in BI-RADS, the only thing that you have to remember is BI-RADS 3, which is probably benign. They'll ask you, what do? You'll follow up after 6 months. If you remember this, that is more than enough, and that's your exam question, right? So BI-RADS may, they'll ask you what is BI-RADS 3 stands for. BI-RADS 3 is going to be in the context of probably benign. The probability of its being malignancy is less than or equal to 2%. 98% of the times it is going to be benign only, right? What will you do? Advise the patient, come back after 6 months for follow-up. Now, when you talk about the breast cancer, okay, I've two important things about the breast cancer. We'll summarize all the important points. Number one, breast cancer is the most common cancer in female worldwide. This is also the most common cancer in females, and that too in India. Most common cancer female worldwide, most common cancer in female India is also going to be breast cancer. If they ask you what is the most common site, the answer is upper outer quadrant. You're going to be in upper outer quadrant of the breast, right? If they ask you what is the most common subtype, it is your invasive ductal cancer. They've asked you previously also what is the HPE finding of invasive lobular carcinoma. invasive lobular carcinoma, remember it is going to be Indian file appearance. It's an Indian file appearance, right? Now, usually they'll ask you about the TNM and the management. So we'll talk about quickly about the T staging, the N and the M staging of the breast cancer. Now, every single time this we've been talking about it, I'll just quickly run through it. This is a representation of the breast. This is a representation of the pectoralis fascia. Behind this, you have the pectoralis major muscle. Then you have the serratus anterior group of muscle. So these are the muscular components that are present, right? Now, when you say the tumors, this is your T1 disease, this is your T2 disease, this is your T3 disease, this is your T4A disease, this is your T4B disease, this is your T4C disease, right? If I divide the breast into equal thirds, if there is an erythema which is present, involves more than 1/3 of the breast skin, this is your T4D disease, right? This is T1, this is T2, this is T3, this is T4A, this is T4B, this is T4C, this is T4D. T1 is less than 2 centimeters in size. 2 to 5 centimeters in size is your T2. Greater than 5 centimeters, limited to breast, it is your T3. T4A is any size if it is involving the chest wall. Involvement of the chest wall. T4B is the involvement of the skin. Now, how do you know the skin is getting involved? The parameters to look for it. Number one, presence of Papez orange. It is Papez orange. Then there is ulceration, the skin ulceration, and then satellite nodules. So Papez orange, skin ulceration, and satellite nodules are the components to tell you that it is involvement of the skin. It is the involvement of the skin. T4C is both skin and the chest wall. Skin with chest wall is what your T4C. T4D is your inflammatory breast cancer. It is your inflammatory breast cancer. This is your inflammatory breast cancer. So when I say inflammatory breast cancer, in the inflammatory breast cancer, it is involving more than 1/3 of the breast skin. It is involving going to be involving more than 1/3 of the breast skin, right? So this is in the context of T stage, right? Now, when you talk about the lymph nodes, N1 is same side, ipsilateral axillary group of lymph node is involved, but this is mobile. N2A is ipsilateral axillary group of lymph node is involved, but this time it gets matted or gets fixed. N2B same sided internal mammary group of lymph node is involved. N3A is going to be same sided apical group of lymph nodes, that is infraclavicular. N3B is same sided both axillary as well as internal mammary group of lymph nodes. N3C is going to be same sided supraclavicular group of lymph nodes. Same sided supraclavicular group of lymph nodes. M nobody cares, it is M0 no evidence of metastasis. M1, there's evidence of distant metastasis. M1, there's evidence of distant metastasis, right? Now, this is what they'll usually ask you in terms of the TNM classification. Then they'll ask you about the staging. Now, again, for staging, I don't want you to overburden yourself. So, in the staging, you have stage 1, stage 2A, stage 2B is there. Then you have 3A, 3B, and 3C is there. Then you have stage 4. Now, the easiest one is stage 1 and stage 4 to remember. It is T1, N0, M0. Here it is going to be any T, any N if M is going to be 1, right? That's it. Now, 2A is going to be your T2, N0, M0 as level up, or it is going to be T1, N1, M0. Sometimes it can be T0, N1, M0 also. 2B will be an upgrade. T2 will become T3, that's T3, N0, M0. T2, N1, M0. T2, N1, M0, there's an upgrade from here, right? So this is what we call it as 2B. Now, the difficult ones are remembered, there is 3A, 3B, 3C. So we say remember this as N2, T4, N3. If you see an N2 disease, it is a 3A. If you see a T4 disease, it's a 3B. If you see an N3 disease, it's a 3C. That's it, right? If these you can remember it, you know your staging also. Now, based upon this, they'll ask you about the management, right? So, stage 1, 2A, 2B is called as early invasive breast cancer. This is called as the early invasive breast cancer. This is 3A, 3B, 3C is called as locally advanced breast cancer. This is your locally advanced breast cancer. And stage 4 is your advanced breast cancer. Stage 4 is your advanced breast cancer. Stage 4 is your advanced breast cancer. Okay. Clear? Just give me a second, guys. Hold on. Right. So this is in terms of the staging and the division. For early invasive breast cancer, you can either do a simple mastectomy. You can do a simple mastectomy or the breast conservative surgery. The current indication for breast conservative surgery is going to be size less than 4 centimeters, limited to 1 quadrant, no evidence of lymphovascular spread, and a solitary tumor. Now, after doing surgery, you will see the node status. If it is node positive or node negative. Node positive, you do axillary dissection. You do an axillary dissection followed by chemotherapy. If it is node negative, you do sentinel lymph node biopsy. You will perform the sentinel lymph node biopsy. For a locally advanced breast cancer, the first one is neoadjuvant chemotherapy, followed by modified radical mastectomy, followed by adjuvant therapy, that is both chemotherapy and radiotherapy. For advanced, it is only palliative management. For advanced, it is going to be the palliative management. Right? So this is in terms of breast cancer. Now they'll ask you the breast surgeries. Simple mastectomy, you remove the glandular stroma, nipple area complex. Radical mastectomy, you do a simple mastectomy, remove level 1 to level 3, level 1, 2 and 3 group of lymph nodes. Pectoralis major and minor has to be removed. In modified radical mastectomy, we will do a simple mastectomy. I will remove level 1, level 2, level 3 group of lymph nodes. I will remove pectoralis fascia, not the muscles, right? Now, what are the structures that are to be preserved in modified radical mastectomy? Remember, is A, B, C and D. A stands for your axillary vein, B is your Bell's nerve, C is your cephalic vein, D is your nerve to latissimus dorsi. The complications which are associated with modified radical, that is flap necrosis or flap gangrene. That's a flap necrosis and flap gangrene. There's also a delayed complication. All these are early postoperative complications. They are early postoperative complications. For delayed postoperative complication, that is around 10 to 15 years after modified radical mastectomy, patient can develop same-sided ipsilateral lymphangiosarcoma. Ipsilateral lymphangiosarcoma of upper limb. And this is called as the Stewart-Travis syndrome. This is called as the Stewart-Travis syndrome. It's called as the Stewart-Travis syndrome. The management for Stewart-Travis syndrome is going to be 4-quarter amputation. This is your 4-quarter amputation. I'm not tired. Yeah, I've been like off late a bit more worked up. I'm trying to give you the best. I don't have my usual energy levels. Yes, that I admit to it. But we'll try to give the best so that we can wrap it up. Don't worry about it. We got your back. See? So this is in the context of breast as well. All right. No sound. Voice. 1 second. Check. No, we got the voice, beta. Can you confirm audio? Confirm. Can you all hear me? Can you all see me? Quick feedback. One second, guys. Not audible. Audio is there, no? Yeah. Yeah, we'll share the PDF also, but don't worry. Sure. So we'll talk about the vascular surgery. We will compare Buerger's with atherosclerosis. Give me a second, guys. 1 second. Hello. No sense. Yeah, I think it is fine now. Chalo. So talk about the Buerger's versus atherosclerosis. When you talk about Buerger's, you will notice that the usual age of presentation is less than 40. Atherosclerosis age about 50. Risk factors for Buerger's, it is smoking. Athero, it is obesity. Most common limb, Buerger's, all four limbs are equally involved. Atherosclerosis is lower limb, far more common compared to upper limb. Size of the vessels for Buerger's, it is small to medium. Athero, it is large to medium sized blood vessels. The pattern of involvement for Buerger's, it is skip lesions, whereas atherosclerosis is continuous. Progression is going to be in an opposite direction towards the heart, right? It is going to be distal to proximal, whereas atherosclerosis proximal to distal. Structures involved is going to be artery, vein and nerve, whereas here only the artery is involved. Only the artery is involved. For all chronic arterial disorders, we do something called as an ankle brachial pressure index. Ankle brachial pressure index is a systolic blood pressure at the level of ankle in response to systolic blood pressure at the level of the brachial artery. See, anywhere in the body, systolic blood pressure is going to be 120 only, so the ratio will come out to be 1. So normal ABPI index is going to be 1 to 1.3. A calcified blood vessel will have more than 1.3. For an intermittent claudication, it is less than 0.9. Rest pain will be less than 0.5. Critical limb ischemia is less than 0.3. Yes, these numbers are important. You have to remember them, right? Now, in terms of atherosclerosis, based upon the level of occlusion, we have three distinct parts. There can be ioto-iliac occlusion. Then you have the iliac occlusion. Then you have the femoropopliteal occlusion. There's a femoropopliteal occlusion, right? So we will compare on the basis of intermittent claudication, whether it's unilateral or bilateral. We'll see the muscle involved, that is your gluteus muscle, thigh muscles, and the calf muscles. Right? Now, in terms of management, what we'll use, and the most common graft. What is the most common graft that you're going to use? So we'll try to decode this table, and that's going to be asked in an exam. So when you have the intermittent claudication, ioto-iliac will have bilateral intermittent claudication. These two will have unilateral. Ioto-iliac will involvement of gluteus, thigh, and calf. Gluteus sparing in iliac, thigh and calf is involved. Both gluteus and thigh are spared in femoropopliteal, only calf muscle is involved. The management here is going to be an ioto bifemoral bypass. So an ioto bifemoral bypass. Here it is going to be an iotofemoral bypass. Here it is going to be an iliopopliteal bypass. Here it is going to be an iliopopliteal bypass, right? Most common graft used is going to be Dacron here. For both aortic replacements, we'll use Dacron. Here it is going to be the autologous reversed. Autologous reversed, great cephalosporin. If this is not in the option, if it is not in the option, then you have to use PTFE. That is polytetrafluoroethylene graft. Polytetrafluoroethylene graft. PTFE, polytetrafluoroethylene graft, right? So this is in the following context. Again, an important table to be remembered. Clear? Chalo. Now, in the varicose vein, we have the SEEP classification. It's the newfound love of your NEET PG. C0, no evidence. C1 is selling ectasia with reticular veins. C2 is varicose. C3 is going to be edema. C2R is recurrent varicose vein. Anywhere you have R, it is recurrent. C4A is going to be pigmentation. 4B is going to be lipodermatosclerosis. Now, the one second, guys. So it's a lipodermatosclerosis. It is because of lipodermatosclerosis secondary to pigmentation. It will result in inverted champagne bottle appearance. It will result in inverted champagne bottle appearance. C4C is coronophlebectatica. It's a coronophlebectatica, also called as the malleolar flare. Also referred to as the malleolar flare. C5 is your healed venous ulcer. C6 is your active venous ulcer. C6R is a recurrent venous ulcer. EP, according to your etiology, is primary. What's already written here? EP is primary, ES is secondary, and no etiology. PR is reflux, PO is obstruction of blood flow, reflux of obstruction, no etiology. Based upon the venous system, AS is superficial, AD is deep, AP is perforator, AN no venous system involved. Investigation of choice is going to be your duplex scan. Remember, on ultrasound, you will see a classical. If there is a cephalofemoral junction incompetency, it will be associated with the Mickey Mouse sign. This will have a Mickey Mouse sign. So when you say Mickey Mouse, a Mickey Mouse has a big face and two big ears, right? So if I equate the Mickey Mouse, now Mickey Mouse, the face is going to be the common femoral vein. This is your great saphenous vein and the common femoral artery. Right? All these put together is what we call it as the Mickey Mouse sign. That is in the context of varicose vein. Now, in the plastic surgery, the grafts are important. We'll quickly review with the grafts. Now, we have two sets of graft, that is a partial thickness and a full thickness, right? In partial thickness, I'll take epidermis and a part of the dermis, and this is called as Triage. Wolfie's graft is a full thickness, we'll take epidermis and the entire dermis, right? Device which are going to use to harvest these are either called as a Humbee's knife or an electric dermatome. Donor side defect in a partial grafting or a partial thickness grafting is going to be partial, temporary, right? That means it will heal. You can take the graft from there. So donor side defect here is temporary, whereas in your full thickness it is permanent. The most common donor site is going to be thigh in terms of partial thickness. Full thickness is retroauricular. There is no scar behind in partial. Full thickness will have a scar. You can take any size in partial thickness because it will regrow back. Full thickness you have to take small because it will leave a permanent defect. The graft survival is good in partial because less tissue. More tissue means more requirement, hence it is poor in full thickness. The secondary contracture is more in your partial thickness, whereas primary contracture is more in your full thickness. Now the contracture defines the cosmetic outcome. Wherever you have more secondary, they will have poor cosmesis. More primary means better cosmesis, and that is why partial thickness is poor, whereas this is going to be associated good prognosis. Now talk about the graft failure. The causes for the graft failure, the most common is going to be the hematoma formation. It is the hematoma and the seroma collection. It is the hematoma and the seroma collection. Then repeated there is repeated movement at the graft site. If you have put it on the joint per se, if there is presence of infection or a wound is infected, if it's a wound is infected, there is absence of periosteum on the bone. Absence of periosteum on the bone. These are the causes for graft failure. Now, I know that these are the causes for graft failure. How do you overcome this? For hematoma and seroma, to prevent its collection, I cannot prevent the formation, I can prevent the collection. We do something called as pie crusting. To address repeated movement at graft site, we will put a joint immobilization. We are going to do a joint immobilization. There is a joint immobilization, and this joint immobilization can be done with the help of a slab. Now, if there is an infected wound, you have to send a preoperative wound site culture. So, preoperative wound site culture. This preoperative wound site culture, the preoperative wound site culture, if there is presence of beta hemolytic streptococci. Presence of beta hemolytic streptococci, that will result in, presence of beta hemolytic streptococci is actually an absolute contraindication for skin grafting. It's an absolute contraindication for skin grafting. It's an absolute contraindication for skin grafting. Absence of periosteum. The periosteum is the vascular component of the bone. If that is only not there, you cannot go ahead with grafting. Now, when you talk about the cleft lip, cleft repair, I've given you all the timings for repairs. That is important. When you say a unilateral cleft lip, a bilateral, okay, we'll just recreate this. This small choto error is there. One second, guys. All right, so when you talk about the repair timings, if it's a unilateral cleft lip, you can repair between 5 to 6 months of age. Bilateral cleft lip is 4 to 5 months of age. If there is a cleft soft palate, it should be repaired at 6 months. Hard palate can be repaired between 15 to 18 months, right? So this is the criteria that we are going to follow. Now, if you have both soft and the hard palate, then the patient will require 2 surgeries. The first surgery will be for soft palate, and that will be done in the 6 months. The second surgery is going to be for the hard palate, that will be done between 15 to 18 months. Now, if a patient is going to have a cleft lip and a unilateral palate, a unilateral cleft lip with a palate is there, cleft palate is there. Again, you will require 2 surgeries here. The first surgery I will do between 5 to 6 months, and here I will repair lip and the soft palate, and again between 15 to 18 months I will repair hard palate. Now, if you have a bilateral cleft lip and cleft palate, again, I have to perform 2 surgeries, right? So, in the 2 surgeries that you have done, the 2 surgeries that you're going to do, the first surgery is going to be at between 4 to 5 months of age. And here we will do clip plus soft palate. And at the age of 18 months, we'll do hard palate. This is the criteria for repairs, right? So all these are important in terms of repair timing. Next, you have the nutrition. In the nutrition, indication for total parenteral nutrition, most important are short bowel syndrome. If the length of the small intestine which is left behind is less than 200 centimeters, it is short bowel syndrome. Then you have high output enterocutaneous fistula. If the output is more than 500 ml in 24 hours. If it is more than 500 ml in 24 hours, it is high output enterocutaneous fistula. Presence of active or acute active inflammatory bowel disease, initial phase of acute pancreatitis, and prolonged ileus beyond 72 hours, right? So in these patients, you can give total parenteral nutrition. The question is, what is the composition and the energy delivered in each? That is your exam question. So maximum concentration of carbohydrate, which will give you 3.5 kilocalories per gram. Then you have fat, which is around 30 to 40%, will give you 9 kilocalories per gram. Proteins is 10 to 20%, will give you 4 kilocalories per gram. So all these are the energy related or released per gram, right? Vitamins and minerals, they are trace, so they will not have much of a component. So usually when they ask you the question, they'll give you 100 grams of carbohydrates. They'll give you, let's say, 200 grams of fat and 50 grams of protein. How much is the total energy that is liberated? So carbohydrate, we know it is 3.5 kilocalories per gram. Multiply this 3.5, you'll get 350 kilocalories. Fat will give you 9 kilocalories per gram. 9 into 200 is 18 kilocalories. Then proteins are going to be 4 kilocalories per gram. That is going to 200 kilocalories. So what is the total energy? That is going to be 2350 kilocalories. Okay. Right. So this is how they'll ask you the question, and this is how you're supposed to answer, right? So this is with respect to your nutrition as well, right? So this concludes your first part of the general surgery that is going to be important, right? We'll take a short break here. We'll resume back in another 15 minutes and we'll start with the second part of it, right? So take a short break. We'll resume back in 15 minutes. Guys, can you all see me? Sure. Right, so we'll continue with the important points in trauma. The first one is the triage. Remember, the categorization of the triad is done on the basis of outcome, not on the basis of severity. So it is done on the basis of outcome, not on the basis of severity. Another important aspect that you look across is the resources that are required for treatment versus resources that are available. The color coding system is pretty precise. Black is dead, red is emergency or immediate attention, yellow is urgent, green is delayed, and blue is going to be moribund. Now, in the terms of hemorrhagic shock, remember in terms of class 1, if the percentage of blood loss is less than 15%, it is class 1. If it is 15 to 30%, it is class 2. 30 to 40%, it is class 3. And more than 40%, it is class 4. Now, here heart rate, BP, pulse pressure, respiratory rate, urine output, GCS, everything remains normal. There is no requirement of blood transfusion. Class 2, heart rate picks up, blood pressure remains normal, pulse pressure is going to drop. Respiratory rate remains normal, urine output starts to decrease, GCS remains normal. Here you give IV fluids, no need for your blood transfusion. Class 3, the heart rate picks up more, systolic blood pressure drops, pulse pressure drops further, respiratory rate increases, urine output becomes oliguria, GCS patient becomes confused. Here, patient will require blood transfusion. Class 4, extensive heart rate increases, systolic pressure drops further, pulse pressure drops further, respiratory rate increases more. Here, absence of urine, that is anuria, is there, and here patient becomes unconscious. In this patient, you will start massive blood transfusion. You will start massive blood transfusion protocols. You will start massive blood transfusion protocols, right? Now, this was your previous exam question also, the classification of head injury based upon the Glasgow Coma Scale. Minor injury is GCS of 15/15 with no loss of consciousness. Mild is GCS can be 14 or 15, but the loss of consciousness is present. Moderate GCS of 9 to 13 and severe GCS of less than or equal to 8. And this GCS of less than or equal to 8 is also an indication of prophylactic intubation. So the minor, mild, moderate and severe head injuries that are associated. Now, usually the questions in trauma is EDH versus SDH. One important thing you need to understand in EDH, it is going to be an arterial bleed. SDH is going to be your venous bleed, right? It's a collection of blood between dura and the skull bone. Here it is between the dura and the arachnoid membrane. It is usually because of temporal fracture causing terion injury. Here it is elderly patient with hit, blow or any componental injury to the head per se. The most common source of bleeding is middle meningeal artery for your extradural. This is your cortical bridging veins. Remember, in both the conditions, there will be increase in intracranial pressure, but in EDH, there is sudden increase, whereas here it is going to be gradual increase in intracranial pressure, right? Now, one of the most important is presence of lucid interval, the characteristic feature. Here it is going to be fixed dilated pupil. Investigation of choice, both the conditions is NCCT. Here you will see a biconvex opacity. A biconvex opacity, which is also called as the lenticular opacity. This is what called as concavo-convex opacity. Here it is called as the concavo-convex opacity and also known as the crescent opacity. Management here is going to be craniotomy, whereas SDH, if it is large, then only craniotomy. Small SDH is conservative. For chronic SDH, we do Buerger hole surgery, and that too, we call it as chronic SDH as chronic if the SDH persists for more than 21 days. Another condition that you have is diffuse axonal injury. Again, a repeat exam question. Diffuse axonal injury is a complete disruption between the axons, between the white and the gray matter. Here the patient will land up to, here the patient will land up into the casualty with coma, and when you get an NCCT done, you see the NCCT is absolutely normal. The investigation of choice is going to be MRI. In an MRI, you will see presence of punctate hemorrhage, and that punctate hemorrhage is between the white and the gray matter. That is between white and the gray matter. That punctate hemorrhage is going to be between the white and the gray matter, and it is associated with very poor prognosis. This is associated with very poor prognosis. One second, guys. All right, guys. Thank you. Yeah. Just give me a second. थोड़ा off लग रहा है आज. ठीक है. Now you can see these punctate hemorrhages between white and the gray matter concludes that the patient is having a diffuse axonal injury. Okay. So whenever a patient has a raised intracranial pressure, in a raised intracranial pressure, they have something called as Cushing's triad. Now Cushing's triad is hypertension, bradycardia with irregular respiratory rate. Whenever you have a patient with raised ICT, how do you manage? Management for Cushing's triad. When you manage the Cushing's triad, intubate the patient and ventilate. Oxygenate the patient. Start the patient on IV mannitol. The target intracranial pressure should be less than 20 and the target CPP, that is a cerebral perfusion pressure, should be more than 60. Should be more than 60. Now there's something called as a lethal triad of trauma. In the lethal triad of trauma, you have metabolic acidosis in association with coagulopathy and hypothermia. How do you prevent metabolic acidosis? By giving ringer lactate. How do you prevent coagulopathy? Whenever you're going a blood transfusion, especially in the massive one, give PRBCs and FFP and platelets in a ratio of 1:1:1. It is 1:1:1. To prevent hypothermia, whenever you're in giving crystalloids, give in the warm condition. So warm crystalloids should be given. Now, stages of damage control surgery has been a previous exam question. Now, stage 1 is going to be patient selection. In patient selection, you should know which patient will require a damage control surgery and which will require an early total care, right? So first is patient selection. Second stage is your primary exploration. The goal for the primary exploration is to prevent any further contamination and control hemorrhage. Then stage 3, it is your ICU care. You will keep it for 24 to 48 hours. The goal for the ICU care, it is to treat hypothermia and coagulopathy. Then you take for stage 4. Stage 4 is secondary exploration. The goal for secondary exploration is to correct the anatomy. And last is stage 5, that is your definitive abdominal closure. That is going to be a definitive abdominal closure, right? So that's your stages for damage control surgery. That has been asked in previous exam also. Now, in the abdominal trauma, usually asked exam question is FAST. That is your focus assessment sonography in trauma. In FAST, we do a 4P evaluation. What is that 4P evaluation? It is perihepatic, pericardial, perihepatic, pericardial, perisplenic, and pelvic. This is your 4P protocol. This is your 4P protocol. Now, in order to overcome this, we have something called as E-fast. E-fast is extended fast. E-fast is your extended fast. In the extended fast, you see the right thorax, the left thorax. Then you have the right upper abdomen, the right lower abdomen, the left upper abdomen, and the left lower abdomen, right? You evaluate all these together. This is your E-fast. The minimum fluid required for the fast to be positive. The minimum fluid required for the fast to be positive is 100 cc. It is going to be 100 cc. Now, usually the USG findings that are asked in pneumothorax, number 1, it is going to be absence of seashore sign. Number 2, it is going to be a barcode sign. Number 3, it is a stratosphere sign. Again, the image, if there's a motion is there, you'll see haziness. No motion, there's loss of haziness. And then there's like absolute like a barcode, right? Now, in terms of abdominal organ, the most common organ injury in the abdominal trauma overall is going to be liver. For blunt, it is going to be again, for blunt, it is going to be spleen. For penetrating abdominal injuries, it is going to be liver again. For car seatbelt, it is your mesenteric tear. And for blast injuries, it is going to be small bowel. It's a small bowel. Now, in the grades of splenic injury, now, see, grading we have done before also. It is going to be on the basis of the extent of hematoma and the depth of laceration. Grade 1, if the hematoma is less than 10%, laceration less than 1 centimeter. Grade 2, it is 10 to 50% and laceration between 1 to 3 centimeters. Grade 3, more than 50% and the depth of the laceration is more than 3 centimeters, right? Grade 4, it is an intraparenchymal hemorrhage. It is the intraparenchymal hemorrhage. And more than 25% spleen is devascularized. Grade 5 is completely shattered spleen, right? Now, for grade 1, grade 2 and grade 3, if they are stable, if grade 1, grade 2, grade 3, if they are stable, we'll go with conservative management. If they are unstable, then I'm going to take for splenography. We do something called as splenography. This is spleen preserving surgery. For grade 4 and grade 5, if they are unstable, then you go an emergency splenectomy. Now, all those patients who have been managed conservatively, I'll repeat CT after 24 hours. And after CT repeating 24 hours, if there's a contrast blush, right, then that indicates the injury is increasing. I'll do an angioembolization. I'll do an angioembolization, right? If the angioembolization fails, then I will do splenography. Then we'll do splenography. Now, post-platelet vaccination is important. 3 important: pneumococcal, meningococcal, and H influenza B. All these 3 vaccination has to be given. If you're doing an elective splenectomy, in elective splenectomy, 2 weeks prior to surgery. And if there is an emergency splenectomy, immediate post-op, I'll give pneumococcal, and in 2 weeks time I'll give meningococcal, and H influenza B. And H influenza B. So this is in the context of your splenectomies. Now, when we talk about the dysphagia, so we'll talk about the GIT from here on. Any patient who's going to come up with dysphagia, we will ask the standard questions, whether it's solids or liquids or only for solids, whether it's progressive or non-progressive, right? So based upon these, I'll give you a few spotters. We'll try to identify the spotters and get away with it, right? Now the first spotter is this. You can see there's a coiling of nasogastric tube. The minute you have the coiling of nasogastric tube, I know it is going to be on day 0, day 1. There'll be registration of all feeds. There'll be continuous drooling of saliva. And here the investigation of choice is going to be contrast imaging. Iohexol is considered to be the safest contrast. It is an iodinated contrast. This is the safest contrast. The most common type, the condition is your tracheoesophageal fistula. The most common type is C type. The other congenital associated abnormalities are Vactral. V stands for vertebral body defect, A stands for anal atresia, C is your cardiovascular abnormalities, that is your patent ductus arteriosus and the ventricular septal defect. Your TE is your tracheoesophageal fistula, R is your renal abnormalities, and L is your limb abnormalities. Then you can see here there is a web that is formed in the cervical esophagus, that is in the upper esophagus, called as the upper esophageal web, seen in Plummer-Vinson syndrome, also known as the Patterson-Kelly syndrome. The Plummer-Vinson syndrome or the Patterson-Kelly syndrome, it is associated with number 1, atrophic glossitis, upper esophageal web, koinonchia, and visceromegaly. So these are the components that are associated with Plummer-Vinson syndrome, or also called as the Patterson-Kelly syndrome, and this is your upper esophageal web. So when you talk about the upper esophageal web, you should also know there's a lower esophageal web. You can see it is at the level of diaphragm. This lower esophageal web is what we call it as the Schatzki's ring, usually seen post GRD, right? Now this is your classical apple core appearance, right? When you see the apple core appearance on a barium swallow, there is presence of shouldering. This is what we call it as shouldering. Apple core sign indicates of esophageal cancer. Then the other thing that you can have is a rat tail. Remember, the rat tail sign can also be implemented. This is considered as a rat tail. Remember, the most common site for the esophageal cancer is going to be the middle 1/3. It is going to be the middle 1/3. The most common type is going to be the squamous cell cancer. The squamous cell cancer is the most common type. The surgeries that you have is Ivor Lewis, McEwen, and Oringus. There are 3 approaches for doing an esophagectomy, that is to be remembered. Another spotter, you can have a posterior diverticulum in the cervical esophagus, that is a Zenker's diverticulum. Remember, Zenker's is an example of pulsion, false diverticulum. The most common site is cervical esophagus. An anatomical weakness is your Killian's dehiscence, or you can say the Killian's triangle. The most important characteristic feature is regurgitation of previous day food particle. It is your previous day food particle. It is your previous day food particle. When you do barium swallow, you will see a pouch filled barium. Management, if it is less than 3 centimeters, you do a diverticulectomy. If it is more than 3 centimeters, you do a endoscopic Dolman surgery, right? So endoscopic Dolman surgery is performed if it is more than 3 centimeters in diameter. Then you have the hereditary cancer syndrome. In the hereditary cancer syndrome, 4 important ones, that is a FAP, Gardner, Turcot, and Buerger. Remember, all of them are going to be autosomal dominant. The first 3 are associated with adenomatous polyposis. So they will be associated with APC gene mutation. Buerger is going to be STK11 gene mutation. Here they will have hamartomatous polyp. So here there is an adenomatous polyp. Gardner will also have adenomatous polyp. Turcot will also have adenomatous polyp. Buerger will have hamartomatous polyp. Peutz-Jeghers is going to have the hamartomas polyp. Now the chromosome which is associated, in APC it is your 5q mutation. This is your 19p, right? The features that you will see, in FAP there should be more than 100 polyps. That's the diagnostic criteria. For Gardner syndrome, there is other components that you can remember as for fed. F stands for FAP, O stands for osteoma, R stands for retinal pigmented epithelium. Retinal pigmented epithelium. F stands for fibroma, epidermal cyst, and the desmoid tumor. So FAP, osteoma, retinal pigmented epithelium, fibroma, epidermal cyst, and the desmoid tumor, right? So these are with respect to Gardner syndrome. Turcot syndrome is basically FAP with brain tumors. FAP with brain tumors, right? Peutz-Jeghers syndrome is going to be polyposis, that is multiple polyps. Most common site is jejunum with mucocutaneous pigmentation. With the mucocutaneous pigmentation. Okay. So this is the familial cancer syndrome. Now we have disorders and the most common type. It's a list that you should know. We should quickly run through it. Now tracheoesophageal fistula, most common is C type. Achalasia cardia is usually seen in lower 1/3 of the esophagus. Zenkus diverticulum is the cervical esophagus, posterior surface esophageal cancer, middle 1/3. Barrett's esophagus, lower 1/3. Plummer-Vinson syndrome, upper esophageal web. Boraf syndrome, perforation in lower 1/3. Mallory-Weiss tear is going to be on the cardia of the stomach. It is going to be the cardia of the stomach followed by gastroesophageal junction. Peptic ulcer disease on the first part of the duodenum. Gastric ulcer is going to be the antrum of the stomach. The antrum of the stomach, and that what angularis incisura. Intersusception in child, it is going to be ileocolic. In adult, it is colocolic. IC stands for ileocolic. Child, it is colocolic. Volvulus, sigmoid colon, and most common is anti-clockwise rotation. Diverticulosis is again sigmoid colon. Again, it is going to be sigmoid colon. Polyps, it is going to be rectum. TB stricture is at the terminal ileum. TB stricture you will see at the level of terminal ileum. Typhoid perforation, most common site is terminal ileum. Ulcerative colitis, rectum. Crohn's disease, terminal ileum. Hirschsprung disease, again most common site rectum. Ischemic colitis, splenic flexure. SMA artery syndrome, usually at D3 compression, and the criteria is if the takeoff angle is less than 20 degrees. Acute mesenteric ischemia, the most common is going to be the middle colic artery. It is going to be acute mesenteric ischemia. The site for occlusion is going to be, the most common site is going to be the middle colic artery, right? Then, so middle colic artery is a branch of superior mesenteric artery. Then a large intestinal malignancy, it is your rectosigmoid. The most common site is going to be rectosigmoid, followed by rectum, followed by sigmoid colon. Perforation in peptic ulcer disease, it is going to be in the first part of the duodenum, and usually it is the anterior ulcers. It is the anterior ulcers that are going to perforate. Then you have hemorrhage in peptic ulcer disease, usually in the antrum. Hemorrhage in the peptic ulcer disease, they are posterior ulcers that bleeds more. The most common source of bleeding in peptic ulcer disease is gastroduodenal artery. The fistula in ano, it is the intersphincteric type. Hemorrhoids, most common site is 3, 7, 11. Anal cancer, it is usually seen below the level of dentate line, right? So this is your table number 1. The table number 2, hold on for a second, give me a second. All right, guys. Continuing. List number 2, we have the named ulcers. We have aphthous ulcers. The most common site or the most common condition is Crohn's disease seen in terminal ileum. Cameron's ulcer in rolling hiatal hernias. Peptic ulcer disease in the first part of the duodenum. Gastric ulcers in the antrum, that is angularis incisiva. Duodenal ulcers in the first part of the duodenum. TB ulcers, terminal ileum. Typhoid, terminal ileum. Bell-shaped ulcers. Bell-shaped ulcers is nothing but tubercular ulcers. The TB ulcer. Flower-shaped ulcer in cecum seen in entamoeba histolytica, serpentine ulcer in necrotizing enterocolitis, cobblestone mucosa, Crohn's disease, solitary rectal ulcer in rectal prolapse, and skip ulcers in Crohn's disease. GI malignancies in the chemo regimes that they usually follow. For esophageal, it is epirubicin, cisplatin, 5-fluorouracil. Carcinoma stomach, epirubicin, cisplatin, 5-fluorouracil. Small intestinal adenocarcinoma is FOLFOX, and large intestine is FOLFOX and FOLFOVIRI both. That is folinic acid, 5-fluorouracil, oxaliplatin, and then you can replace that with irinotecan. Now, the GI margin for resection for esophageal proximal margin is 10 centimeters, distal is 5. Rest everywhere, the proximal and the distal margins will remain at 5 centimeters. Let it be stomach, small bowel, large bowel. All of them is going to be 5 centimeters. Rectum proximal will remain 5, but the distal will become 2 centimeters, right? So, two important factors to be remembered here. In esophageal proximal margin and in rectum distal margin is different. Rest everywhere it is going to be your rectal cancer. Better necrotizing enterocolitis will have serpentine ulcers or serpiginous ulcers, right? Now, list 3 again in the chemo regimes only. Anal cancer, that is squamous cell Negro's regime, 5-fluorouracil, mitomycin C with radiotherapy. Gist is imatinib. If it is resistant to imatinib, then you can give sunitinib. For imatinib resistant gist. For imatinib resistant gist, you can give sunitinib. Then you have hepatocellular cancer, sorafenib. Gallbladder carcinoma, gemcitabine with cisplatin. Cholangiocarcinoma is gemcitabine with cisplatin. Pancreatic ductal adenocarcinoma is gemcitabine, right? Then you have disorders and its management. Now, achalasia cardia, management is Heller's cardiomyotomy. Diffuse esophageal spasm, usually it is medical management. If the surgery has to be done, then it's going to be long esophageal myotomy. Zenker's diverticulum, we've already dealt before also. More than 3 centimeters, then you can do a Dolman's. It is a Dolman's endoscopic surgery or Dolman's surgery. Esophageal cancer, you have 3 techniques that we have. You have Ivor-Lewis, McEown, and Oringers. We have Ivor-Lewis, McEown, and Oringers. For congenital hypertrophic pyloric stenosis, Ramsay's pyloromyotomy. Perforation, peptic ulcer disease, Graham's or mental patching. Peptic ulcer disease, triple or quadruple therapy. For GERD, you can do Nielsen's fundoplication. D1 stricture is Heineken muclids, or also you get Jabulois pyloroplasty. Or else you can do a Jabulois pyloroplasty. For duodenal atresia, duodenojejinostomy, jejunal atresia, jejunojejinostomy. Ulcerative colitis is going to be total proctal colectomy with ileoanal J pouch anastomosis. For diverticulosis, it is elective sigmoid resection. For FAP, it is the same. FAP is also total proctal colectomy with ileoanal J pouch anastomosis. For rectal prolapse, it is going to be Thierch-Weiring, Repstein's, Altamier's, and Freichmann-Goldberg. For Hirschsprung disease, it is Duhamel, Swenson's, and Soas. For hemorrhoids, Milligan, Morgan, and Ferguson surgery. Adenocarcinoma of anal canal, APR, that is your abdominoperineal resection. Now, in the liver resection terminologies, When you evaluate, this is the representation of the liver. Dead in the center, you have the Cantill's line. And through the Cantill's line, you have the right hepatic vein, the middle hepatic, so left hepatic, middle hepatic, and the right hepatic vein. And then you have the portal vein, which is running like this. This is the orientation for the portal vein. This is your segment 2, this is segment 3, this is your 4A, this is 4B, this is 5, this is 6, this is 7, and this is 8. Right? This is the orientation of the liver segments that you need to keep. 1 second. All right, so when you talk about the liver resection terminologies, right? In your right hemi liver or right hepatectomy, what are the right side? See, this is the right side of the liver, this is the left side of the liver, right? So this is the right, this is the left. So what are you removing on right? 5, 6, 7, and 8, right? So here you go, you remove 5, 6, 7, 8. On the left side, you remove 2, 3, 4A, 4B. Then you have right anterior. Right anterior is of which one? This is your 5 and 8, right? So right anterior is 5 and 8. Then you have right posterior, which is 6 and 7. Then you have the left lateral, which is going to be 2 and 3. Then you have the left medial, which is going to be 4A and 4B. Then you have right trisectionectomy, which is going to be 5, 6, 7, 8. Then 4A, 4B. This is nothing but extended right hemihepatectomy. Extended right hemihepatectomy. Then you have the left trisectionectomy. Here you have 2, 3, 4A, 4B, and 5 and 8 included. Right? So this is with respect to liver resection terminologies, right? Now, when you talk about the infections in liver, the three major ones, pyogenic, amoebic, and hydrated cyst. You know, pyogenic is going to be bacteria, other two are parasites. Pyogenic is caused by E. coli, Klebsiella, whereas your amoebic liver abscess, the name itself is saying amoeba, that's Entamoeba histolytica. Your hydrated cyst is caused by Echinococcus granulosus, and that is what we have mentioned it here in terms of causative agent. The route of spread for pyogenic is bile duct, the other two is going to be portal vein. The age for pyogenic is more than 50. The other two is going to be relatively younger. That is, amoebic is 20 to 30. Hydrated is 40 to 50. Pyogenic more common in males. Your amoebic colitis, amoebic liver abscess is also more common in male. Hydrated cyst is equally seen in both males and females. All infective disorders are more common on the right side. Bacteria are multiple. The other two are going to be solitary. You can never have bacteria to be endemic. The other two usually are endemic. The clinical presentation, how do you know? Here it will have pain, fever, and jaundice. Here pain with colitis or history of, there will be history of colitis. there is history of colitis and mostly hydatitis asymptomatic. The first investigation for all of them will remain ultrasound. For hydatitis, there's a Gerby classification. To confirm it is aspiration culture, the other two is going to be ELISA. But if I say what is the investigation of choice in general, it is going to be CECT. For all abscesses must be aspirated or basically drained out. So pyogenic liver abscess, USG guided aspiration with antibiotics. Here it is high dose metronidazole. Usually we give 700 to 1000 milligrams TID for 14 days. For hydatitis, we do something called as the pair therapy. Now, pair stands for puncture aspiration of hydrated fluid with installation of scolicidal agent and reaspiration. It is puncture aspiration with installation of scolicidal agent and reaspiration. The scolicidal agents are hypertonic saline, 10% povidone, 0.8% centramide, and 0.05% chlorhexidine. Right. So these are with respect to the infectious disorders of the liver. There is a comparison between the hepatocellular cancer and the fibrolamina variant of HCC. When you look at the comparison between both of them, HCC versus fibrolamina variant, the HCC is more common in males, fibrolamina is equal in male and females. The usual age for HCC is 5th decade of life. Fibrolamina is 25 to 25 is the average age group, right? It is 25 years. Tumor nature for HCC is poorly differentiated, whereas fibrolamina is well differentiated. Resectability for HCC is around 25%. Here it is around 75%. Association with liver cirrhosis is present in HCC, not in fibrolamina variant. Hepatitis B is also associated here, not here. AFP status is elevated where fibrolamina is normal. Remember, the tumor marker for the fibrolamina variant is neurotensin B and B12 binding protein. And the B12 binding protein. The prognosis here is going to be poor. Here it is relatively good. In the cystic lesion of the pancreas, you have pseudocyst, serous cyst, mucinous adenoma, and the intraductal papillary mucinous neoplasm. Right. Now, the most common cystic lesion overall is going to be the pseudocyst, but if there's a cystic neoplasm, that is going to be the mucinous cyst adenoma. The usual age of presentation for pseudocyst is 40 to 60, serous is 60 to 70, mucinous is 50 to 60, IPMN is between 50 to 70 years. You will notice that when you talk about IPMN, or I can say the other components, pseudocyst is more common in males when compared to females. Serous is also more common in females. Mucinous is more common in females. IPMN is males and females equally seen. In fact, pseudocyst, no, it is equally seen in males and females, not more like this, right? Now, in appearance, you can see the pseudocyst is usually solitary. It is solitary large. Serous adenoma is multiple. Here, mucinous cyst is going to be thick walled. And a very important, there is this calcification which is present on the periphery called as peripheral axial calcification. And here you will have fish mouth ampulla. Here you have the fish mouth ampulla. There is, if it is associated with chronic pancreatitis, there is ductal communication. There is no ductal communication here. Here it will have ductal communication. The most common site for the pseudocyst is lesser sac. Serous cyst is equally distributed. Mucinous cyst is body and tail, whereas IPMN it is going to be head. Now this is the most important from the exam perspective. Mucin stain here is going to be negative. Here negative. Mucinous adenoma and IPMN, both of them, the mucin name itself as mucin. CA is going to be normal here. It is going to be normal here. It is going to be elevated in these two. Amylase will be elevated in IPMN and pseudocyst. It remains normal here. Investigation here is going to be CECT. Here also it is CECT. Here also it is CECT. Here you will do an ERCP. You will see presence of fish mouth ampulla. There is this fish mouth ampulla is noticed. There is this fish mouth ampulla that is noticed. The management for the pseudocyst of the pancreas is cystogastrostomy, cystogenostomy. For serous cyst is enucleation. For mucinous is distal pancreatectomy. IPMN is near total pancreatectomy. The last important is the important triads that you will see in the your GIT and the X-rays. The first one is your Carney's triad. Carney's is just paraganglionoma and pulmonary chondroma. Next is your Mackler's triad, which is seen in Boerhaave syndrome. This is associated with retching or vomiting with retrosternal pain and surgical emphysema, that is subcutaneous emphysema. Then you have the Bouchard's triad. The Bouchard's triad is where a patient is having, it's in gastric volvulus, associated with pain, retching without vomiting and inability to pass nasogastric tube. Then you have the Murphy's triad seen in acute appendicitis, which is associated with pain, vomiting and fever. Then you have the Charcot's triad seen in cholangitis. All of them are going to be intermittent, that is pain, fever and jaundice. Then you notice there is Quincke's triad, also called a Sandbulum triad or the triad of hemobilia, where you have pain, jaundice, melena. You have Gusac test positive, that is for occult stools, blood for stools. Tilloch's triad, again previous exam question, seen in mesenteric cyst. Here the patient is going to have mid-abdominal cystic swelling, only mobile perpendicular to the root of the mesentery, and a band of bowel resonance in front of the cyst is what we call it as Tilloch's triad. Now, the first imaging that you have is an ultrasound. This is the ultrasound for CHPS. The criteria or the components that you will see here. Antral nipple sign, you have cervix sign. The length of this thickening should be more than or equal to 16 millimeters. Width is more than or equal to 4 millimeters. In a contrast imaging, you will see a double track and mushroom sign, that is also in congenital hypertrophic pyloric stenosis. In a hollow viscous perforation, you have free gas under right hemidiaphragm. It is seen in perforation peritonitis, typhoid ulcer perforation and appendicular perforation. If there is a delayed presentation of hollow viscous perforation, in a delayed presentation of hollow viscous perforation, you will see presence of football sign, dome sign and the Wriggler sign. Wriggler sign is basically visualization of bowel wall, also called as a cupola sign, right? If there are three things, as you can see, there are three components, A, B and C. What is A? A is going to be stone, B is going to be obstruction and C is going to be pneumobilia, right? Now this is what we call it as Wriggler's triad, right? So Wriggler's triad is going to be small bowel obstruction, it is small bowel obstruction with pneumobilia, with ectopic gallstones. Now this is seen in your gallstone ileus. This condition is seen in gallstone ileus, and the most common cause is bilioenteric fistula, and the most common site for this fistula is between the duodenum and the gallbladder, that is a cholecystoduodenal fistula. Double bubble sign you will see in your duodenal atresia and annular pancreas. Multiple air fluid levels more than 3 in a step ladder pattern is small bowel obstruction. If you see a hair tuft which is called as trichobezoar or secondary to trichotillomania. This is called as the thumbprint sign seen in ischemic colitis. The most common is splenic flexure. This is the accordion sign seen in pseudomembranous colitis. You can see the air presence of bowel loops in thorax. Indicates it's a congenital diaphragmatic hernia. It is your congenital diaphragmatic hernia. Now, if it is on the left side, this is your Borstalek hernia. Apple core sign is seen in various components, esophageal cancer also. But if you see these hostrations are present, that is seen in colon cancer. Claw sign, intersusception. If you do a technetium 99 per technate scan and there's presence of ectopic foci. If there is an ectopic foci, then it is your Meckel's diverticulum. The rule of two is seen in 2% population, 2 inches in size, 2 feet proximal to IC junction, 2 different mucosa. It's an example of true diverticulum, and the rule of two is there. The most common tumor in Meckel's diverticulum is your neuroendocrine tumor. It's going to be neuroendocrine tumor. If you have a coffee bean sign, it is your sigmoid volvulus. If it's a bird of prey sign, again it's a volvulus. If there is presence of sawtooth sign, it is your diverticulosis. If there is inflammation, if there is an inflammation, of this diverticulosis, this will now be called as diverticulitis. And the classification for diverticulitis is Hinchey's classification based upon CECT. Haggett's is for polyps, right? Do not get confused between Hinchey's and Haggett's. Hinchey's is going to be for diverticulosis, Haggett's is for polyps, right? Coming down to the last leg, this is your nephrolithiasis. One second, guys. All right. Now, in the nephrolithiasis, we have the calcium oxalate, phosphate, uric acid, and cysteine stones. The most common is going to be the calcium oxalate stones. The most radio-opaque is phosphate. The most common radiolucent is uric acid. Hardest is going to be cysteine stones. The causes for calcium oxalate is hypercalciuria, phosphate is protease infection, uric acid is gout, cysteine is because of cystinuria. The characteristic features for calcium oxalate, they'll have sharp projection, they're dirty white. Phosphate stones are triple stones, true white stones, or also called as staghorn calculi. They're called as true white stones and staghorn calculi. And the staghorn calculi. Uric acid is formed in acidic urine. So whenever the stones of the uric acid are formed, they're because of acidic urine. So here the management will be alkalization. There is alkalization of urine. Cysteine is sulfur containing. When you talk about the radiostatus, calcium oxalate, phosphate, and cysteine are radiopaque. Cysteine is radiopaque because it contains sulfur. Sulfur is radiopaque in nature, right? Uric acid is radiolucent. Uric acid is going to be radiolucent. Uric acid is radiolucent. Now, this is your exam question. They've asked you the crystalline images on a microscope for these. For calcium oxalate, it is going to be envelope shaped. It will be envelope shaped. Phosphate, it is going to be coffin lid. Uric acid is multi-faced. And cysteine is going to be hexagon. Or because it looks like benzene, it is also called as benzene shaped. Also called as the benzene shaped. Right? So this is all in all with respect to all the important topics of the surgical marathon that you should remember in terms of FMGE exam. Just go through all these topics, do a quick revision. Most of the things you have already read, you're confident. Your job is to go, revise and repeat it. I'll be sharing the PDF soon with the team as well. They will share it across with you. If you have any questions, you can reach out to us as well. You can write it on my personal Telegram, Instagram, as well as PW Meded Instagram and Telegram channels. We'll be there to help you out. All the best for the exam. Thank you so much. Take care. Have fun. Bye.